So I've sent things on silent, please, and we're getting Ian online, or we're getting Ian, for those who don't know Ian, but he's not arrived as yet. He may well. Other than that, I have no apology this morning. So it's getting to be a significant amount of this. Right. So, and we have with us Sue from the value circle this morning, obviously part of the well-led work that is beginning today. So be aware, and with 360 Assurance with us this morning. And we might have Cora online as well, possibly, or even more possibly in the room, but not yet. So thank you for that. Could I remind everyone who isn't a board member that we are a meeting in public, not a public meeting. There will be time at the end of the meeting if anyone has any questions. For those who are not members of the board, please come and go as you please. If you want to leave early, please do. I will be doing the normal video vlog at the end of the meeting. And so that's okay. Can I welcome Dr. Rumit Shah as our new Associate Non-Executive Director to his first meeting. And indeed, that makes 2 GPs round our board, which is really good news.
It's like they haven't got any other work to do, isn't it? Extraordinary. Don't minute that.
Absolutely. There, of course, is with us as our next director, but I don't think it's his first, not your first meeting, is it, Shani? Simon, is it your first meeting in person? Yes. at the board? Yes. So good to have Simon with us as our Director of Finance and Estate. If there are subsequent questions, you can, of course, always give them to me or to Toby after the meeting. If things crop up, please don't think you can't. And if we do have members in the public anyway, I don't think we did. Questions to Phil by midday at the 3 o'clock public question session. Could I remind you, I will stop talking to him. Could I remind you that we do have a couple of items where we are simply taking questions, as we've done in the past. Phil, remind me which those 2 items are, or can you remind the board which those 2 items?
The paper later on around euro weights and the one around the promise 2 and the carers.
Yeah. So can we remember that questions only to those 2? We won't take the reports first. And just a slight alteration to what you would know as our agenda, the patient story will, for reasons of those people who are involved, will be taken first thing after lunch. So we wouldn't normally have it now. So it's
Kath,
is it just before?
Catherine, I just take the opportunity of that to apologise to the board that the patient story will not be told by a patient. There are all manner of reasons for that, and it's not a situation that will occur. But I thought it best to say that now because I don't want the staff who are coming to tell what will be a very interesting story to feel like I'm sort of throwing shade on their contribution. So apologies starting there, but that's where we are.
No, thank you. Phil tells me it's just before lunch, not just after. So thank you. I think that is the whole of the announcements. So no apologies for absence. Thank you. We are obviously for it. The declaration of interest paper is there. So declarations from Mr. Shepherd, it says, very formal, and Dr. Shah are included in the paper. Shabir's have been received and will be in the document for next time. So can we receive and note the depth of interest, Steve?
Can I just make an amendment to mine and Dr. Graham? So the QNI is the QCIM.
Right, okay. Okay, thank you. Can we note that amendment, please? We received the declaration of interest paper?
Yes.
Thank you. And we go to the minutes of the meeting of the 16th of December. So can I first take them on accuracy, please? Is everybody content with the accuracy of those minutes? We then receive them.
Kath, can I just note, I'm very happy with their accuracy. just so colleagues are joining the dots, clearly the CAMS medical staffing proposal, which is referenced in the minutes, it is made clear in the private minutes from last time's board that we're not proceeding with it. So it's not a minute inaccuracy. I just don't want there to be any confusion.
Thank you, Toby. So to matters arising and follow-up actions from those minutes, we are recommending the closure of 4 actions and it does provide a clear forward plan for all of the remaining 10. Is there anything you want to add to that, Phil?
No, hopefully people would content that the page provided and show where they'll be receiving papers over the next couple of months. Meetings.
Anyone on any comments on the action list? I think it is quite clear there's nothing for those items that are not closed. It's clear what the direction is in the timescale.
So in order to avoid the impression that when it says the chief executive is on progressed and overdue, which is 25/11/23, I'm expecting it to be progressed and not overdue by next time. Everyone's been too polite to say it.
Thank you. But can we agree to close those 4 items highlighted in green? Thank you. And we'll move to reports of the assurance committees, two committees. Can we take the reports as read and take questions once we've had the chair highlights? Can I start with Richard and Quality Committee, please?
Thank you, Chair. Legislative paper as read. In the matters of concern, you see Rotherham remains an outlier in several metrics, which is quite a vague statement to just throw into the board minute. There's nothing there that's ringing great alarm bells, and we did talk about the way that the Quality Committee is going to look at deeper dives and not be quite so formulaic in its approach. So this is just really the conversation. And we've also had meetings elsewhere about insights, Toby and others we spoke last night. And I think this sort of ties into that there's just a little sort of question mark being raised. So it's mentioned rather than escalated, to put that into context. There's a fair amount of the other stuff on the agenda for today that's being progressed. A comment around the piece of final report. Moderate assurance, people might think, well, why wasn't that significant assurance? It was basically that the audit was undertaken early on in the process, and there's very much a feeling that if you were to be doing it now, it would look much more towards significant. In terms of highlights, I think probably the biggest highlight is to see where we are with complaints. That when I started 18 months ago, the backlog was enormous, and really just to make sure that that's documented, that the work in addressing complaints is very much on track, and very pleased with that. Yeah, most of it's on the agenda today, so
Thank you.
happy to take questions.
Any questions to Richard on the report out of Quality Committee? Toby?
I should be encouraged by the statement about PSERP and expecting significant assurance next time. Somebody just give me a clue as to why we have such confidence. I don't say not have that confidence, I just think it'd be helpful. Because it's a complex area, so to progress is challenging.
This is Toby. I think there was something about the timing of the audit, given that we just agreed on the PSERP new approach, with the refreshed approach at board, and then the timing of the audit was within the next kind of 4 to 6 weeks. As such, there were a number of recommendations that actually were already in train, because at the same time, if you recall, we'll be reminded that we also implemented a new reporting system, RDaSH.
Yeah.
So those 2 things combined have now embedded and settled in. So certainly some of the areas from the 360 audit around the triangulation of learning for other areas of PSERP, so not the serious investigations as were. So when we undertake an investigation with a group of individuals unconnected with the event, the other 3, so after action reviews, MDT and swarm huddles, those 3 areas we haven't historically in the organisation been able to demonstrate the learning. So they've taken place, but then what hasn't happened is that hasn't been recorded and then shared across the organisation. So what we've seen in Quality Committee is that we're now able to articulate, and Dr. Falk as the chair will either affirm or deny this, is that we present what after action reviews have taken place and also what the learning is from that. Importantly, we have board oversight of that, but of course, the important part of that linked to the learning, education and learning plan is showing that across the organisation.
Yeah.
So you cannot, so I suppose practically, Toby, and this was the main part, I almost want to look over to my right shoulder to see if Laura's nodding.
Well, I don't care what 360 say in those, but I'm interested in your perspective.
So we have built into RDaSH the ability that we don't close any of those other elements of PSERV, so after action review, SWARM or MDT, until learning is uploaded and evidenced, and then we've shared it across, and then it's closed.
I'm feeling very reassured. Thank you. It's really helpful. Thank you.
Guys.
Yes, please. Yeah.
So Promise 22, when I read it, clearly we're trying to change the ethos of working across the board. And 7-day working certainly is becoming more and more important. Yet we are in a position where, yes, that's where we want to be, but we cannot have assurance that that's going to move at any point in time. So I just wonder how we go about mitigating that.
It's a good question, and probably a deeper question that we've got a moment here to fully explore. So the thing that will happen by March is Steve and the team will have completed an audit of where we actually are. So we really understand our baseline. You and I will both have an instinct about where we're. You'll recall in what we call the SDR, and other trust boards you've been in would call the BAF. We have a specific risk that Richard's in charge of. What we have to decide, I think, in, let's just say, the summer, is okay, given that baseline audit and given a BAF risk in which jumping alone is probably problematic, because, you know, it'd be lovely to have everybody working weekends, but they'll all go and work somewhere else and don't have to work weekends. What are we actually saying we're going to do? So I'm sorry, I'm giving you a timescale and not an answer, but I think it's the summer when we need to sort of form a view about, okay, what are we really going to change between now and 2028? Maybe the other thing to say in advance of that is that Promise 14, the urgent care bit of it, sometimes known as the what happens when you refer me a patient on Friday. Monitoring for that has started. Richard may want to come in, and I think we will be able to see over the next few months exactly where we are in progression. But you're absolutely right. It's a big deal.
Did you want to come in?
Yeah, I think Dr. Sharp, were you at the Quality Committee? I can't remember. Yeah, so the brief update did mention that if we all jump, it puts us at risk, because I think all the mental health trusts locally are all grappling with this. It would be very easy that if we jump first, people would go, yeah, no, we're not going to work here, we're going to work there. Particularly, let's say, medical colleagues. So I think we have to make a very careful, considered system decision rather than an isolated mental health decision. I think the other thing to bear in mind as well is that in the papers, Retova Support invested in a community development director. It's over the next year, while neighbourhoods are flavour of the month, everyone's still slightly different. So I think there'll be a strategic change brought through the neighbourhood working, of which will be not necessarily inpatients, but we'll be asking services like community services to work differently. Because the current concern of inpatients is, well, we can't discharge because there's no community support. Yeah, apart from home treatment, which is more of an acute or crisis service. That's not only ourselves, that's the local authority, that's CV.
Yes.
So if we jump, the anxiety will be we discharge patients into a vulnerability, which we need to work through. So I think we have to allow this neighbourhood working work to emerge over the next 6 months to start to inform the shape of where our community services are going. It's because I think inpatient discharge relies heavily on the shape of the community offer.
Right, can we agree then to receive the report from the Quality Committee? Audit Committee, Kathy?
Thank you. It's very much a sort of mid-term in the financial year, as far as it goes in terms of the agenda. So there were no matters of concern or key risks to escalate to the board. There was, just to really call out some of the highlights, there was really positive work, progress with the internal audit, keeping on top of recommendations, keeping on top of the risks, risk reviews, things like that. Really good progress. Progress is more than that, more dynamic, working in the fraud, counter fraud space. So with regard to investigations and training, and interestingly, thought whether that increased training and awareness has actually, you know, helped to create space to raise things safely and then, you know, address those that are addressing. I think I just want to commend like the collaborative work about the audits going into the other committees. I think that is really helping now and really a strong thing to be doing. So I think that's really good because there's ownership and progress and so on. So I just want to, you know, recognise that because I think that is contributing a lot. So I'll take any questions about that.
Questions to Cathy on the audit committee report? If not, thanks, Cathy, and we'll receive that report. Yeah. Sarah, Mental Health Act Committee.
Thanks, Cathy. So you'll see that the two issues that we wanted to draw the board's attention to was the continuing compliance performance of Rotherham. For us, it's consent to treatment, for example, rather than compared to other sections with 2 rights is persistently low. We know work's going on and we are expecting to get up to it in March. So we know that the those that need to be are cited on it, but we just wanted to say it's still an issue and we didn't want the board to lose that. The other area of concern for us is compliance with MHA level 3 and RRI training. We've been working closely with those who are trying to develop this to get a better return for us, but I think everything that's been tried is not actually getting any traction at the moment. So you'll see in the paper that's coming up around needs training analysis that we'll look at that there is a specific section in there to ratchet things up a bit so that we can start to take some concrete action, because we don't think it's good enough to think to patients at risk. And I think our view is that if we're expecting the training to be done, it's been done for a reason. I think it's good. So we just wanted to, we know it's coming up, but we just wanted again just to put our weight behind that. And the board will know that we've got 2 areas of particular focus. One is section 132 rights. That was going in the right direction for a while, but it's now a bit more sporadic. It's a bit more hit and miss. So more work is going on in relation to that. And the other focus area for us was section 136 suites. For some time now, we've had a 100% success rate in terms of assessing patients for 24 hours. So that's continuing, although this time what we did see was that all of our suites were closed at some point, and it totaled 14 occasions, whereas it was 2 last time. Now we know it was for operational reasons because but we just wanted to let you know that nevertheless there is that effect. That there is that effect. Just to mention.
Go on, Richard.
Just a point of clarification, just if you can, when you say closed due to operational reasons, I just want to check, was that section 140?
I think one was. Do you want to?
I'm trying to remember the exact numbers, but I think a number were the section 136 week could be repurposes of that.
So that's not closed.
No. I think there was maybe from memory, but I think it was perhaps 1 or 2 140s. But I think there were other reasons.
Well, it is closed.
Being used.
Sorry, it is closed. It's not being
purpose.
used as a section 136. So you know, it is closed for purposes of our policy. Yeah.
But to be mindful, we have raised as we reduce our hopes and manage things differently, we thought there might be a lever in terms of the set use of the 136. It's part of just trying to understand all of that. So, yeah.
I think it was just the spike really. I just wanted to make you aware.
Has that spike? I don't think that spike's carried on.
So that was, so I did raise that in last month's IQPR,
Yeah,
that it was a spike. It said it's potentially a concern in terms of if we're managing more in the community and reducing patients, we may hold a bed, someone on the section 140 overnight, to move them into a bed the next morning rather than them going out of area. So I may not see it as a negative thing.
No.
And I suppose it's just trying to understand, because if you go close, you're bad. It may be, but it may not be, because you know, Steve and I sort of managed over the weekend. We might be saying, keep the patient here on Sunday. It closes, but we have got a person leaving on Monday. So rather than send them out of area, so I think, you know, but ultimately we need to have the bed capacity over the weekend. But that's just some of us, we work reduced homes.
That's really helpful. So what might be useful for us perhaps is just to see perhaps a bit more narrative around the
Yeah,
reason.
I was thinking that
So
there,
we can-
that's what you
We can
need.
temper it a bit more rather than,
And triangulating, obviously, because I did note it in the IQPR that was a spike, and we need to just keep a watchful wait on it. I don't think it's as high this month. So I suppose it's using other sources of information.
Make sure that Sarah's committee gets that extra information.
just try and understand that a bit better. And then just very finally, you'll know that the committee has felt that as it's maturing, it wanted to give its focus to more developmental activities. And the one area that's regularly appeared on our reports, for which we haven't really had a clear understanding as to what the committee should do with it, are blanket restrictions. You know why they're there, they serve a purpose in the organisation, but we hadn't really got on top of why we were looking at them. So we had a really good presentation from Jude a couple of meetings ago, followed by a paper from Steve, just to get the ball rolling in terms of reflecting the trust-wide practice of trying to get all our blanket restrictions into the same prevention policy, and what might the committee want to see. And then when we get that paper in a really good position, then we can have a good sense of what it is we want to take assurance on, or what we want to be convinced of.
Yeah,
So I see that's a really positive thing.
absolutely.
And it's a committee being able to look in depth at developing things.
No, that's much.
That's it from me.
Just building on that theme, we're going to have next time a really good paper on reducing restrictive interventions. We had a really good discussion at the last meeting with a slightly wonky paper, but that was fine. What was really encouraging about that was that we were able to get a lot more data. It's kind of to Steve's point about radar, a lot more data about repeated use of particular medication, repeated restraint, so on. So I suppose on something, you know, this time last year, we were talking about ROI as a board, if people remember. Steve Keller and colleagues' presentation.
Yeah.
We should have all of the ward advocates in by April, and then this committee can look at whether we're really making meaningful ROI progress, and we can chart a bit of a course to next year. Because I guess if we imported a group of staff who work in our wards of all the things we've talked about in the first 20 minutes, that just feels like a really big one.
Yeah. Thanks, so very active committee. We received the report from Sarah's committee. Thank you. People in OD, Rachel, please.
Yeah, thanks very much, Chair. And I think really important to reflect the ongoing contribution and challenge from our governors, Ian and Richard, which I really think shapes the conversation that we have and really grounds us in what we are there for as a committee, and obviously thinking about the delivery to patients as well, which I think is really useful. There's a number of things that are on the agenda, so I don't want to duplicate. We obviously recognise the staff survey and the reduced response rate in line with the NHS nationally, and we look forward to the how those results then feed into people promise themes and understanding the each individual care group. Our focus for the last few meetings has been really getting to grips with the data, and we're now in a position where we have what we call these top 10 measures, which I think really helps us focus as a committee. Great discussion about what the data was telling us and grouping the data as well. So in future, we'll be looking at 3 measures every meeting, really doing that deep dive and understanding, and then obviously making recommendations to the board. I think Kathy picked up in terms of internal audit and the recommendations. So that's something that we discussed, because often our focus at this group is the RDaSH and the violence and aggression against staff, and how we deal with that. Positive highlights to note is the real living wage and the impact that's having, and I think we shouldn't miss that, especially when we've got so much else going on. We had a really good discussion about the training needs analysis, but that's on the agenda as well. And I think it's just that, if we don't get a chance to say it today, the variety of opportunities that we're providing for our staff, not just for their personal development, but how that impacts and how that delivers that holistic care and support for our patients. And then just to note the resident doctors industrial action and the impact there. And good to note that there was no impact on services with all shifts covered, and contingency plans ensured continuity to operate effectively and safely.
Thank you, Richard. Any questions to that report? And obviously, yes, Sam.
Yeah, one comment and one question. Just building on the matters of information, just for the board to note, subsequent to this, we have received £200,000 to support the trust action costs,
even though it hasn't cost us anything. No, well,
yeah,
may as well
no,
be
it's,
explicit, just
yeah,
illustrate
so,
the craziness.
Yeah, all providers have received a allocation based on submitted data. So I just wanted the board to be aware that will be reflected in subsequent reports. So that was a comment. In terms of the question, noting the 49.3%, were there any outliers in terms of whether it's care groups or backbone areas that may require additional focus?
Our response rate overall was lower than previous years, but that is following a national trend. Most organisations are trending lower this year with an element of survey fatigue. We always have corporate backbone areas responding much more than our clinical corporate areas, but there was a fair spread across the clinical areas. When we do have the results, we have the functionality just to have a look at the staff groups that have responded in the clinical areas to make sure we've got that breadth. So it's not all administrators in clinical areas, it's not all nurses in clinical areas. So we do slice the data in various different ways.
Okay, so yeah.
And it's particularly our senior doctors group takes particular interest in the staff survey, isn't it? So that's encouraging as well. Can I just make a slight plea, and this isn't meant to be irritating. I just wanted next. I'm slightly losing the thread of A, B, C. So my memory of the people and teams plan is it's got A and B and C, and I'm not going to embarrass myself. I try to remember what all of them stand for. I think it's attract, belong, and then the other one, cultivate. There you go. I would find it helpful as we go forward, particularly if we're thinking about these top 10 measures, to be able to link them back to A and B and C, because my concern is to make sure we're devoting collectively, not your committee, sufficient time to all three, if that makes sense.
Oh, yeah.
Is that okay? Thanks ever so much.
You're
Yeah.
really feeding,
Thanks.
so.
Dermot.
I was just going to make a brief comment about the resident doctors industrial action, in that I think there probably has been some cost, because in order to cover the first on calls, a significant number of the shifts had to be covered by internal locums, and we were paying up to £70 an hour. So it wasn't that there was no cost during the working day. We were able to run the services without incurring any extra expense, but during kind of the on-call shifts there was.
Yes, forgive my cynicism, though. I can get a bailout for that, but the national pay award is not.
That was okay.
So forgive me, but yeah, I take your point.
Yeah, thank you, Dermot, for that. Can we receive the report, Rachel's report? Thank you. Pippa, Dave, please.
No matters of concern or risks. Just a couple of things to point out. Good progress on veterans, good progress on the adult eating disorders collaborative. And then one to watch was around the link between what we call the RDaSH 5, as well as the overall E&I plan, equity and inclusion plan. A lot of plans, clarity on data, clarity on targets, but seeing mixed results. Some of which are very early days and very understandable. So to borrow a phrase from Toby's Promises report, getting gritty on health inequalities, I think was the phrase that you used. So how do we sharpen up the work that's going on and make sure that we're getting the returns that we expected? Second one to point out really was about Promise 15 about neighbourhoods. Just included that just because of the national focus and national importance of it. We know what we've got going locally about 2 pilots, one in Rotherham, one in Doncaster, and the physical health improvements and community teams. But I think, as Richard said, this is unfolding and unfurling, and I think we took the steer to say, let's come back at that in Q1 when we have that additional management capacity to focus on it, not least because people are a bit full on at the moment. So we said we'd come back in Q1. We did include it in the whole board pack because I just thought it was a really good summary of the national picture and the local picture, just for other colleagues' awareness. And then just the last one, just from a board perspective, because it came up at the last board, the use of the phrase global majority. When we were going through some of the data, sometimes we meant global majority, sometimes we didn't, and sometimes it was confusing rather than illuminating. So what we just said we do is take a bit offline and to just make sure we've got clarity and consistency in the way that we use phrases, because it was getting unhelpful in the discussion. So we just wanted to
thank you.
raise that.
Yeah. Questions to Dave on this report?
Chair,
Yes.
just a comment. So with regards to veterans, following that meeting, it so happened that I've got a patient in front of me, and he was so very impressed with Op Courage, and he was quite willing to come as a patient story at some point in time if we actually ever wanted that. So, you know, anybody wants to get in touch with me, certainly get in touch. Yeah.
We will be in touch. Absolutely.
Thank you.
Thank you. Thanks very much. We'll receive Dave's report. Yep. And move to Pauline on FDE.
Yeah, 3 areas of risk, but also opportunity in there. FDE. So we looked at the year to date with the main focus on the forecast by this time of year. So still forecasting to break even, which I think the board's fully aware of, and recognise the risks around capacity fill, the high dependency, the rehabilitation unit. I think I have a bit of an update on that today, and deficit funding. So no surprises there. It's on track to where we thought it was. And Waterdale lease, again, we've had board sessions on that. FD's got oversight, working closely on that one. So that's progressing. The trust procurement function, merging with Sheffield, again, an update, but I think there may be further update on timing. I'll ask Simon to cover that one. And then, as we have been doing for months now, looking at the medium-term financial plan, and again, the board's aware of that, focus on the CIP, cost improvement savings, and we're again supporting, working with finance team for submission for the 12th of Feb, so to support that one. So I think you're well cited on those. We looked at health and safety compliance, and I think just the board to note, fire safety was quite a big issue last year for us, and we've seen significant improvement on that area, and it's been sustained. So we'll continue to monitor that. I think that's important to note that here. And then highlight the ambient voice technology. We received an update on the pilot, which is going to be important for us going forward to deliver productivity and improvements for patients. So, the pilot results should help inform the investment decisions going forward. So again, we're keeping up to date with that, linked to the digital enabling plan. Thank you. Simon?
Yeah, thanks. Like just a few further updates. So acknowledging 29th of January, this is about month 8, just to give the board assurance, month 9 figures are absolutely in line. We are still formally forecasting break even, and that is after losing Q4 deficit support funding because of the wider South Yorkshire integrated care system performance. So we have lost £609,000. That's absolutely guaranteed, but we are still formally forecasting delivery of that, which is really positive. In terms of procurement, the executive team at Sheffield supported the proposal, and it was going to their board yesterday. So I'm chasing a outcome of that, and then we'll meet with our team next week in terms of progressing that over the next weeks. Couple more comments. The Waterdale issue, we have now got confirmation. We have secured the 3.4 million increase to our CDL capital budget for this year, which is again really positive. And the final one, very, very small point around the internal audit, talks about was expected to be finalised in March. It will be. I'm looking to take an update to audit committee next week on that, because I think that's for me, it's not about the sort of the KPIs within the health, it's using those. to improve the services that we're providing across the organisation. So I'll give an update audit committee next week
Yeah,
on that.
that's really good news. Can I say just to point this over, I had a trip out to the development at Phoenix and to Great Oaks this week with Maria, who is our capital programme lead, which is saying in my completely out of my head.
Management.
Very impressed. So things go very well. Nearly there on board. So staff are very, very excited. So it's really is to see.
That's what it's all about. But I also add my thanks to Jill and Maria for, covering the finance and estates role. And we've now got Simon at the next meeting, but appreciate the work we've put in dual roles, haven't we? So that's been nice.
It's all looking good out there. It's great to see. We
You
received.
get the neurodiversity centre in Bentley.
We've got
So
that
thank you
one.
there, yeah, that's
Got that one.
fantastic.
It was not exactly the day for being outside a lot, was
We'll get you a bike. We'll get you.
terrible day to what day to pick for a second. Thank you. Can we receive Pauline's report? And lastly, Dave, TPC from yesterday, I'm assuming.
Yes, so just said Carleen, I didn't know how much to share about them. Because we could spend hours talking about the richness of the conversation. And yet, given everything that's going on and the fact that we had about half the members there, what we committed to was sharing the outputs from yesterday to all those members that weren't able to attend yesterday, and then we build into it. But just a hint of it. Thanks to Carleen and team for the design and delivery. There weren't any papers. It was just a room, and it's just some seats to chat about culture. And the power of conversation and commitment and insight of people and the bravery to share their view, and but sometimes on behalf of their allyship, on behalf of colleagues, was fantastic. It was profound. And it just struck me again, the power of conversations to shift culture. We have to do this stuff together.
Yeah.
So I'll probably leave it at that point, unless Carleen or Toby or Cathy, if you want to take it.
Hugely enjoyable. What did we have, an hour and a half?
Yes.
Well, it was a hugely enjoyable time, wasn't it? And I have to say that I think our staff governors particularly, whether it's in the governing body or yesterday at TPC, have been just tremendous.
Yeah.
Absolutely tremendous. They're not, their scrutiny and challenge is significant, but it's respectful and they are very much on board. And what they add to those conversations is really, really significant. I enjoyed particularly their input yesterday. Jude.
It's really good to hear what you're saying around the different methodologies used as well, because we know people don't learn and analyse always through papers. They don't really know. Obviously, some of our folks on learning will talk about that, and we've got a vlog this month that's talk a bit to that. But the conversational style is enabling as well, isn't it?
Yeah.
Because otherwise the power's not there. Actually, empowering the narrative can be hugely beneficial. So although the content obviously isn't huge in here to see what it was, do let's think about how we learn from what we did in there, because actually that would lend upon the other things we've done. We're trying to really emphasise that kind of storytelling and enabling active listening, and how that then changes followership in terms of what we're doing.
Yeah. Actually.
Won't take too long on this because we could be here all day on it. And Richard.
Yeah, I mean, it's great to hear that's the positivity there. I suppose we just also have to acknowledge that we're going through a very considerable change process within our community services, and to triangulate that, we're in other meetings where the unions are sort of quite active in their sort of discussions, which may or may not go into that meeting. So I think it's just it's really, that's a forum and it's great, but a culture won't be through one meeting, I suppose. And I suppose as a board, we just got to sort of hold on to all of the different elements of that.
And that sense did come up, Richard.
Absolutely.
What would our international students say about this? What would other colleagues say? So I think it painted a rich picture of multicultures that exist and constantly subject to change.
So I think two things. Well, one, I think the content will be visible in April, May, and there's quite a lot of work. Different. I think the second thing is, I think TPC really sort of proved itself yesterday, actually, for me, in that it was a really balanced conversation. There was plenty of the things Richard's alluding to, but there was quite an organic balance, which was quite impressive to see people hold. If you said to me, for all the reasons you're alluding to, it would have been quite easy for yesterday to be, and that would have been fine. You know, if you forgive me, it's a bit shit around here and it's really difficult.
Yeah.
And I want to talk about it. Now, there was a space to have that conversation, but that didn't take over the entire conversation. And I think that, you know, to your point about staff governance and actually others, I mean, you know, the BMA Local Negotiating Committee lead doctor, for example, I thought was very balanced. So I think it was helpful.
Yeah.
And in some ways, it showed what the collaboration should be. And as Richard's alluding to, there are other spaces that are probably not here where that's more of a struggle. To be honest, and you know, almost if we could have videoed that yesterday and then shown that some of these other spaces, you know, one might see the difference. So, but yeah.
No, thank you, and we'll celebrate where it goes well. It wasn't easy. It wasn't as though they were just. They are very challenging. You know, they are very challenging there, but it's in the right way, the right way. Really good. Thank you. Can we receive that report? And with no more ado, move to Toby's report at agenda item 14.
Thanks, Chair. So I think let me say two or three things that are either not in the report or just to amplify them. So firstly, I appreciate everybody will have opened their copy of the Financial Times this morning to see pictures of Steve and others. And I guess that's part of a concerted effort in a number of media, and obviously FT is not particularly the obvious one, to just really narrate the 4-week achievement. And I think if we get to the point where people are saying, "Oh, for goodness sake, enough already! Could you all stop talking about it?" Maybe that's okay. But I do think, and I said this, I did a note to everybody who works in the organisation yesterday about the forthcoming change, and towards the end of that were sort of 5 things we were asking of people, and one of them was to not forget the positive things staff are delivering alongside the difficulty, and I do think that's really important. And to be honest, as leaders, if we don't insert that, other people won't have the permission to do that. I was with a group of staff at the TPC yesterday who were actually talking about their experience of trying to support staff who were going through change and how exhausting they were finding that, in a sense, because it did sublimate some of the positive things that they wanted to talk about. So, yeah, the FT is a hook there, but if I've grown its readership by 15, then there you go. That's my contribution. So that was the first thing I want to say, which is a point about success. Second thing I want to say is that the board will remember in, I'm going to say July 2025, after the Supreme Court judgment in relation to a specific question in a specific case, sometimes misrepresented as the Supreme Court's view of the definition of what a woman is. We made a decision here to change, to take down and amend some of our policies over the last couple of weeks, probably on the back of the nurse case in Darlington. We've received increasing interest in that space, and we've made some additional amendments to our policies and removed 1 or 2 of our policies, pending the long-awaited and much delayed ECHR, or whatever it is. I misquote the acronym guidance, the timing of which I still have no idea when I'm going to get it. So colleagues are very aware of where we are with that, but it's worth mentioning it to the board because it feels like business. So 2 other things, and then I'm very happy to take questions, including the one about AI that's in the cover sheet. So I think we're wanting to walk the right balance around long-term sickness over the next 6 months. The balance between our sickness is higher than any of us would want, versus the need to make sure we're supporting people who need to not be at work but have a 30-year career, and actually if they miss 6 months, they miss 6 months. That will work with that. I was really encouraged in delivery reviews on Monday and Tuesday by care group. I'm sure that corporate directorates will demonstrate the same at the end of February, but care groups will focus on long-term sickness. We were seeing an expectation of, material reduction, but compassionately. So, this is a long game, but it's just worth emphasising, I think, that on the back perhaps of Carlene's sickness clinics, there's some encouragement of people's grip. We're also going to bring in some other agencies to help us with that space, because we're not a neutral employer, but we're not seen as neutral in sickness situations, in particular at time of change. I think potentially different entities having conversations with staff who are off sick who are not us is a worthwhile thing. I'm aware that about 5-6 years ago, RDaSH tried this and it wasn't wildly successful. That's fine, that's acknowledged, but I still think there is an opportunity where if the person talking to me about my long-term sickness isn't my line manager, and I'm not sitting there thinking you're basically just trying to get me back to work because there's a target about sickness, maybe that's a helpful intervention. So just to highlight that. And then finally, I don't want job planning to sort of slip off our collective radar. We've said we're going to job plan Band 7 nurse consultants, Band 7 AHPs and psychological professionals, and clearly all of our senior medics. Lots of work has been done. It remains incredibly foundational. We won't be able to implement the organisational change stuff properly in Q1 unless we have got cohered job plans. That doesn't mean the implementation group for that are there to do job planning. That's not their job. But we must have that in place, and contained in the audit programme for next year, subject to the view of the audit committee, will be a series of very detailed audits that look at whether those plans are real and so on. So I think job planning is maybe just something I'm trying to make sure we hold collectively together and don't either assume it's done or swerve round. I mean, I'm happy to leave it at that, Chair, and then if people have got questions or comments on anything in the report, I'll take those. Thanks.
I've got Jude and Dermot and Carleen. Jude?
Yes, thank you ever so much for the report. I had a question around job plans, but you've answered that. But my second question was around there's several improvements mentioned throughout the paper, particularly around neurodiversity wheelchair services estates that are really dependent on some commissioning decisions and partnership behaviours. And at the moment, the landscape we're working in is unsettled. So I guess it was just an ask around the fallback and the escalation around that.
Yeah, I think. Okay, so just to, sorry, the question doesn't need amplification, but just to speak to it. So clearly we're trying, and there's a paper later, to move neurodiversity services onto a different funding. And onto a position where our services and the shared care arrangements across South Yorkshire in particular are standardised. I think there are goodish papers being considered by the ICB this week that would support what we're trying to do. I think there is a really difficult conversation about funding for mental health and mental health related services with the local ICB. I think it might be the case that their instinct is to commit such growth as they have to other things, and I think that's problematic. So I don't have per se a mitigation at the moment. I'm optimistic that will move forward. I'll say more about that on that paper. And in terms of wheelchairs is one of 2 or 3 services, not 6 or 7, but 2 or 3, where we'll look to change the contracted basis of how we work. I think we're cautiously optimistic that we'll manage to get that through the process. Or I'll put it like this, almost unless people make such a fuss about it that folk realise what we're doing. And 1 or 2 people have seen some of the email correspondence. Yeah, I'm keen to dial down let's talk to the ICB at multiple levels about that, because it rather gives it a place that isn't very helpful. But I'm optimistic that will give us a place where wheelchair funding going forward, it isn't effectively funded by us in some way. So I think I'm optimistic of those. I mean, the estate changes more generally. I had a really positive meeting with Rotherham Council this morning. That was very encouraging. People will remember that when Simon comes back, we talk in March. Yeah, Rotherham is slightly the key because it's the bit we haven't resolved. So equally, there's a long way to go on that, Jude. I'm not trying to avoid any of your questions, but that's my sense. That's my sense.
Thank you, Dermot.
A couple of things. I just thought it's worthwhile kind of highlighting the DVLA because I think that's really good evidence of MDT working. The fact that we've managed to clear that backlog because that had really impacted on some people's lives. So that's kind of fantastic for that. The second point was just about job planning. This is obviously kind of an open gambit from the BMA, but just to kind of put on people's radar, the current clinical, non-clinical split is 75-25%. The BMA is attempting to negotiate a 70-30 split when they're kind of looking to renegotiate the national contract for consultants.
Oh, right.
Just to kind of be aware that's kind of something that they're trying to pursue. It's obviously not something that has been agreed, but just to let people.
I'm really relaxed about it, 'cause to be honest, if we get RDaSH 2.5, it's an advance on where we are and an advance on where everybody else is. So, you know, that will be what it will be, but we need to get to that point. The tricky bit is to get to a point where 1.5 of those 2.5 are being used for the things that the institution needs, educationally and research and leadership wise, without trying to anticipate conflict and therefore bring it on. I could imagine in the early months of next year, that becomes a tiny bit problematic. I think colleagues were encouraged to find that we were so supportive of 2.5 SPAs, which many trusts aren't.
Yeah.
I think for some colleagues, SPA time is seen as my time.
Yeah.
And I get psychologically how that is very important. So we've got to pull off the trick of it still feeling like my time whilst contributing to the whole. We need more people involved in research. We need, so that's going to be our challenge. That's going to be our challenge.
Yes, please. Question about job planning. So, first of all, it must be a contractual requirement that you must have job planning in place. But with regards to what percentage are actually approved and signed off by the time is 1st of April?
So the answer to that question is I'm completely relaxed if we're at 0% approved and signed off. We're at a very low percentage at the moment. The reason I'm relaxed from it is that we're essentially, as RDaSH, trying to introduce not that bad. trying to introduce job planning. I think job planning previously, as in a lot of trusts, has been perhaps closer to a diary card. Yeah. And I think we're working through, we had good collaboration. The policy was finally agreed in November, that this is a more mutual activity and does involve sometimes me asking you to do things that weren't your suggestion. So I think the standard we should set ourselves is by the 1st of July. I'd be really disappointed if we haven't covered everybody off. Does that make sense? And we're in good dialogue with the regional office who, just worry about the fact that we're at X%, but that's where we are. Does that make sense? I think it's a really helpful question. The other thing to understand is that we're trying to job plan all of our senior clinicians, not simply our medics, and that is quite unusual and important, I think, particularly if we're trying to create teams or nurture teams.
Richard, you come in on this one for bring Carleen?
Yeah, it sort of ties in with the question about AI. In 3.5, the last sentence, says frank conversations about where these technologies are replacing paid hours of work. Is that sort of part of this, that you're freed up by the technology, but that doesn't mean that you're not doing other things instead?
Okay, so when I wrote that, I was, we need to be honest with our staff that in 2027, 28, so a year and a bit from now, we will radically change the administrative model, potentially clinically and corporately. And we need to be honest with people as we're adopting AI, that's part of the conversation. The alternative narrative, which is to reassure people that it's not and then pop up and be a bit surprised next April 27, doesn't appeal to me. And from reactions around the room, I'm not in a minority, so that's good. I think there is an honest conversation with clinical staff about where we can use AI to do things they're currently doing. We are not in the main yet at that point, Richard, but we're building the capability to get to that point. Particularly around sort of screening, triage, etc. You know, maybe in the space that Roman was asking about earlier in terms of weekends and so on. So
I guess from a clinician's point of view, Jeremy, someone says that's brilliant, you don't need to spend hours producing this report. You think that's great because I've got loads of other things to do already. Not, yes, somebody's got something else for you to do as well as all the other things. I guess
it's definitely the case. I know you need to move on, Cap, but it's definitely the case that that the principal barrier to more patient contact time is administrative surroundings efficiencies, and if we can get that to be better consistently, it'll be easier for colleagues to do what we're asking them to do, which in a lot of cases is quite a lot more patient contact in various formats than maybe has previously been the case. Not in every bit of the organisation, but you know, there are specialties. I mentioned one earlier on in the minutes where the level of patient contact that's going to be needed from our medical staff will be 2 or 3 times what it currently is. 2 or 3 times what it currently is.
Thank you. Callie.
2 points, 1 question, 1 reflection, and it does touch on section 3.5. So the first question in relation to 1.2, the 4-week rate. We talked about the 4-week rate and the success here at various different committees, but if we think about ward to board, do the 4,000 or so RDaShians have the same understanding and are able to articulate that success and that achievement in the way we describe that?
So I think increasingly, and I think increasingly is because many people have moved through the phase of this is just a lot more work. And I think because colleagues are beginning to sustain it. I think, as you know from delivery reviews, we've got some work to do on things that sit around the 4-week wait. So unallocated patients, administrative clearance within a week. And the reason I think that really pushing this with staff, you know, it is useful to be done when we've just nailed off a few of those things over the next few weeks, Colin, is I think one of the behaviours that happens with staff as well as elsewhere is we don't really mean it. It must be a fiddle. Yeah, it must be. It's a confidence trick. You know, it's 4 weeks, but something else and but that. Now, most of those examples are wrong. Some of them aren't. It's not a fiddle, but some of them are not daft. You're doing that, and therefore this is waiting. So I think once we think I think out of DRs, a lot of those things we can nail off over the next 8, 12 weeks. Not everything, but a lot of them. Then I think you're right. We need to be building a sense of pride about it, and that's why we keep mentioning it. Do we think everybody recognises it's important? I don't know. Let's see. But people should be proud. Yeah. They really should.
And then the second part, building on 3.5. So we've touched on ambient voice technology and such like. There's various other tools that are available, and we made an informed decision earlier this year not to progress the administrative review as part of our cost improvement into next year because we weren't ready.
Yeah.
Our workforce wasn't ready. So that was purposefully delayed for a year. But we've had or having frank conversations with those individuals about this will change your way of work, just joining up some of the dots for a paper that's later on in the agenda, the training needs analysis. We've also got a cohort of colleagues that don't feel confident, don't have that digital literacy. So we need the time to embed that digital literacy and the training needs going into next year.
Thank you. Very quick comments, Dave.
No, I just think it's important to recognise on your reports, Toby, the mental health app bill receiving royal assent in the appendix, and the considerable amount of work that will undertake as part of the training needs analysis. So I think it would be remiss of us not to acknowledge.
No, that's right. And I mean, Jude contributed to us trying to help the ICB board 6 or 8 months ago, as Dermot did with his video, to understand what this meant. Memories are short. So as we have the conversation about the £3.9 million gap between the material £3.9 million gap between us and commissioners, that is one of several issues, Steve, that we are trying to help people to understand.
Thank you.
I come in, I did get missed in, is that okay?
Very quickly.
Yeah, it's at 3.2 and it's something for March really, but I just want to put a mark on the stands really. I'm just interested in this, the third bit about the right way to support colleagues, so on sickness absences, who feel unable to work owing to their disagreement with trust policies or practices. I just wonder if we could have a little bit of influence around that in March to try and get a feel for whether there are things in our policies that might put people who feel professionally challenged, maybe.
You can have a little bit of information about it in May.
Or is it?
Because I think, or a little bit more, because I mean, we'll talk some more about it in March, but I think we need to, we're going to need to come at this quite gently. And I suppose May, I know it says March, it is slightly further on from the consultation. But what we're talking to there is the difference between being off sick because I'm sick versus being off sick because this has happened, this change is happening and I don't like it. And at the moment, both of those things are captured through sickness, and we are going to explore a different way of separating those two things. But we will be breaking, the NHS doesn't normally do it this way, other industries do. So sorry, I didn't mean to, you can have as much detail as you want, but I suppose in terms of in the board and in public, I might want to have a little bit of clear red water between the consultation.
1st of April.
Yeah, a little bit. Because, I mean, clearly there is a possibility of the manifestation of some of these behaviours over the next few weeks. I mean, it's unavoidably likely.
Thank you. Got your
just to expand on that example, to give you a real life example from over the weekend, which isn't associated with change management. We needed to redeploy a nurse from one ward to another ward, and the one ward where we were redeploying from was already above the safer staffing numbers. The nurse refused to work on that ward and in essence withdrew their labour, went home, and the message on the Monday morning is, I have 4 months contractual sick pay based on the length of service. I'm going to be off for the next 4 months. So there's examples not associated with change management where we need to work through some of those challenges, which we most definitely are, but that's an insight.
Thank you. Thanks, everybody. Could we agree to receive Toby's report? I think we have explored and considered.
Sorry, Chair. Toby did ask the question in that final paragraph about engagement with the board with the ambient voice going forward, what the board's preference will be.
Right.
I know we had the previous sort of small review group hosted by Dr. Mike.
Yeah, I mean, I think
to move into an end of evaluation similar.
Yeah, well, and then we're going to. I think if colleagues feel they've been sufficiently involved through that process, by the time we get to March, we'll have made some decisions.
Yeah.
I suppose if people are sitting here having read the paper thinking, no, I want to be much more involved, then I'm sure we can accommodate that.
Absolutely. If they want to get in touch with me, Toby, I'll
that'd be helpful. That'd be helpful. If people want to get more involved, because this is going to be, a moderately big deal as we go through the next little while.
If anybody hasn't seen Mike's presentation, for instance, please do talk. So looking at the recommendations we have explored and considered, I think can we particularly note the progress being made towards the 12th of February revised national plan submission, just so that we've got that minuted and that's done. Thank you. Thanks, Toby, for that. And we'll move to Dermot's report on the learning and prevention of future deaths. Important report, Dermot. Thank you.
Thanks, Kat. So just to kind of briefly mention what PFD reports are in case people don't know. So during a coroner's inquest, if there becomes matters of concern which the coroner believes may lead to future deaths, if action's not taken, that can lead to them producing Regulation 28 reports or a prevention of future deaths reports. Interestingly, they don't necessarily need to be, the concerns don't need to be causative in the death at the inquest. If something comes up coincidentally, which was unrelated to why the person who the inquest is being undertaken for died, but still the coroner believes it may lead to other deaths, they would still kind of issue a Regulation 28 prevention of future death report. So it's just important to probably make that, because I think that's actually, as we work our way through the paper, that's probably equally true of some of the PFD reports that our trust has received as well. That some of them weren't necessarily directly contributing to the deaths, but they were still kind of PFD reports issued. That's not to say that they're kind of not important, but just to kind of set the context and kind of how these reports get written. So having done that, the coroner will formally write to the bodies involved, which they believe ought to take action, and then they're recorded on a national database, which is published on the judiciary website. Anyone can access that. It's completely publicly available. There are kind of other tools that can break it down in more detail, such as geography, kind of time frame. For the purposes of this paper, we looked at mental health related deaths, and essentially what the methodology was that we extracted the verbatim text of the coroner's concerns from those 180 PFD reports from the beginning of January 2023 till December 2025. And so we kind of sucked all the text out of those PFD reports for that 2-year period, and then summarised what those themes were from the coroner's own words. And so you can see kind of that they kind of do kind of cluster into a number of themes that keep on repeating. And as I mentioned, when we kind of get to the PFD reports that have been issued to the trust, you'd actually see that they kind of fit that national pattern as well. There wasn't any kind of particular new themes that didn't fit those national themes and our own local ones. You'll kind of notice that there was 180 kind of these looked at, but if you add up the number of themes and the number of PFDs, it's well in excess of 180, and that's often because we work in systems, and so it's very common for a coroner to identify kind of more than one theme, an area of concern. So that's the reason why it's in excess of 180. So that's kind of the methodology of how we did that. And so kind of as we kind of look at that, the areas of concern do align with areas of work that the trust has been doing bits of work in. So if we look at the kind of continuity of care and transition, and so that can be transition points from service to service, so community to inpatient, but also potentially primary care to secondary care. So there's all sorts of kind of potential kind of transition points, and those are kind of particular kind of points of vulnerability. That does align with some of the work that we've been doing with HQTC historically, that we haven't had particularly good attendance of community teams at ward MDTs. And obviously it's really important that when we're potentially discharging a patient back to the community, that the community teams have the opportunity to be involved in that care. And so by kind of altering the meeting structures, that's something that we're hopefully from March going to be confident that we are going to have better attendance to reduce the chances of that discontinuity of care. Also, we've also had kind of issues where people have gone to out of area providers, and if you have someone who was, if we think back to a couple of years ago, we had people going as far away as Bristol for an inpatient admission. To organise a successful community discharge if someone's in Bristol, coming back into the South Yorkshire area or North Lincolnshire area, it's incredibly difficult. And so again, that work that we've been doing to reduce out of area admissions is really important to kind of reducing the chances of unsuccessful discharges. Another kind of key area is kind of risk assessment. There's been national guidance issued in terms of used suicide prevention. One of the key messages from that was that we shouldn't be globally stratifying people into high, medium and low risk. And that was something that was kind of quite standard practice. And it was actually indeed referenced in several of our own kind of policies previously. And that's something that we're kind of gradually, as we're updating our policies, looking to remove, to kind of take on board that national guidance. And so that's not a piece of work that's complete. That's something that we are actively progressing. We're kind of the staffing situation. Obviously, potentially, if you have not enough staff on shift or not enough resource for community teams, that can potentially create risk as well. And I think hopefully the board will be cited that we've done lots of work on safer staffing, and also in terms of our community work and community service redesign, there's been an awful lot of work undertaken in terms of capacity and demand to look at that sort of issue. In terms of communication, information sharing, this has kind of moved significantly further forward during my own career here. We used to have systems that didn't talk to primary care. For a large number of our patients, we now use the same clinical system as people working in primary care, so that they can see what I'm recording on the record, and equally I can see what primary care clinicians are putting on the record, and equally we can see each other's prescribing practice as well. So that's all kind of a very kind of welcome change. I think the other thing that's kind of important, as well as that kind of information sharing kind of between different services, there are still some weaknesses just to acknowledge, because if we had a patient that was, for instance, in an acute trust, we do still use different clinical systems. We rely on people writing letters to one another. So there are still some weaknesses, but potentially we do have some, historically we've had weaknesses sharing information within services by having different care plans being used in the community, and then potentially the inpatient people not kind of communicating what people are hoping to achieve from an inpatient admission versus kind of what we're hoping to achieve in the community. And so by introducing dialogue and kind of using the Dialogue Plus to have a single care plan, we're hoping to reduce those occasions where people, things kind of get lost. So we kind of keep that kind of golden thread kind of going through a patient's care, so kind of knowing what the key aspects of care are, so that so that's kind of less likely to happen. Another kind of aspect is obviously the kind of the learning that happens, and I think Steve's kind of spoken already to how we're trying to ensure that learning from incidents, because we're always going to have incidents, is embedded from the trust with the changes to radar, the P-serve approach. So I don't necessarily kind of want to speak too much to that. And then lastly, kind of policy. I think coroners kind of regularly identify that people set themselves policies which they then can't implement. And that is something that we've kind of relatively recently seen when it comes to our inpatient leave policy, that we probably designed a policy that was almost practically impossible to achieve. Do we think that some of the work that we've done in terms of the engagement disengagement policy, one of the things that delayed that being approved by CLE was the fact that it needed testing and that buy-in from the clinical services, that it actually was achievable and practical, because it was all very well and good setting out the ambitions of what we should do, but if it wasn't achievable, then there's no point necessarily kind of writing a policy in that context. So those are kind of in broad strokes the kind of the national areas, and so you can then see kind of the detail of the two PFDs that the trust has received in the last 2 years. So kind of one in May 2023, and that the coroner identified concerns around there being no effective follow-up following a patient discontinuing taking their antipsychotic medication. and also kind of that failure to work with partner organisations, in this particular case, drug and alcohol services. So as part of the PFD process, it will be expected that the bodies that have been issued the PFD paper would be asked to send a response to the coroner, and in that response you would set out what actions you're going to take. I suppose a potential weakness of the PFD system is that the coroner doesn't actually go on to check that you have implemented that. So it's the onus is on the organisation to ensure that they've taken the action, rather than that there being kind of statutory process to ensure that that's being taken. So I've kind of set out in the table that what actions that we said that we're going to take. The in terms of a number of the actions, you'll see that they're kind of rated green, i.e. they've been implemented. The in terms of the kind of the ones that are amber green, the engagement disengagement policy that has been ratified in 2025, September 2025. The reason why I've not marked that as green is that I think there's further work to be done to evaluate the effectiveness of that. And I think until we kind of see that evaluation, I'd be reluctant to say that that's an action that's been successfully implemented. And so that's the reason why that's kind of rated amber green rather than green. The other action that is amber red, and because I put that because I think we know we have a plan to implement it, but it's not something that we've started to implement as of yet. Is the what we said we would do is identify the core policies that certain cohorts of staff needed to know and to have read. We are still doing that work where we're kind of identifying the core policies that people need to know, and also kind of breaking down the individual cohorts, because there might be, you can't just go and say we want all inpatient nurses to read these policies, because we have physical health wards as well as mental health wards, and so actually the nuance of what the exact cohorts are going to be is actually is quite tricky, and does need some careful thought given to it, because if we set the cohorts too broad, we potentially will end up with a situation where we have to give large numbers of policies for people to read, which then potentially becomes unachievable in the time that people have to complete their mast. So that was the actions in relation to the May 23. In terms of the September 24 death, that was in relation, the coroner identified that there was no access to crisis services to those aged over 65. And going back to the point I made earlier on, I think, having kind of written the chronology for this case, I don't think that the fact that there wasn't the crisis response necessarily did directly cause this death, but obviously it was an area of concern for the coroner, which is the reason why we got issued the PFD report. And then there was also kind of the secondary issue of kind of the information that at the time our position that you couldn't be referred to the crisis service for over 65 not being shared with partner agencies such as 111. So those were the areas of concern. In terms of kind of where we are with that, we are now accepting crisis referrals for all over 18s into our crisis services. The reason I've rated that as kind of amber green rather than green, although we have implemented it, is I think we'd agreed that we'd do further evaluation of that. And so kind of I'm reasonably confident that in a few months that we'll be able to rate that as green. In terms of kind of the other kind of amber green actions, obviously that's kind of in relation to kind of our Promise 14 work, and we're making some great kind of progress with that, and we're hoping to achieve a lot of that by March. But I suppose I would want to kind of rate that as green when we've actually achieved that, rather than kind of the trajectory that we're hopefully on. I hope that makes sense. Also,
but I have to bring you to a conclusion, Dermot. Sorry.
Well, I think it's. I'm happy to kind of finish up there. Just also to kind of, I suppose, a bit of good news, just to highlight. As part of our work as the provider collaborative, we've done some fantastic work in terms of supporting improving the need pathway. Just to highlight, that wasn't a Regulation 28 issue to ourselves, that was issues to kind of the system. But obviously it does directly affect the care of patients that are in the trust. And so I think that, that's a very important thing, a very positive improvement.
I'll bring Richard in a minute. I think the just want to get through this report and Carlene's report on training before we break for coffee. Technically 11:35, so just bear that in mind. It's important about this report is that we do, that you read it and understand it, but that we do recognise that we need to see this report annually. And so this report will repeat itself in Q4, 26, 27, and we'll be back. And this is incredibly important that we manage and recognise the need for this board to know these matters. I mean, Richard and then Dave, and Kathy and everybody on the planet. You won't get coffee.
I put my hand down.
I'll be cancelling the coffee break at this time. Richard, Dave.
Thanks, David.
And I'll take everybody else.
Trying to be brief in context of coffee is more important. It comes annually, but this is being seen through a different lens of quality. And really, it's not rocket science, the things they do. It doesn't apply to people who've died. It applies to people who have lived through without even knowing there was an issue, and people who have had harm because of the same issues. And it really just referenced people back to my report. I didn't pick up at the time, but the National Report Benchmarking Summary against Greater Manchester started off as a piece of work where Steve basically just went across it. But what it's morphed into is actually an oversight of all the things that we're doing. So if people want to specifically see that, it might be worth sharing, Steve, outside, because hopefully it gives people the reassurance that there really is a good focus on this and that we're doing an awful lot of stuff already.
Yeah, absolutely. And this is national scandal stuff, and we need to make sure that this board is assured and aware of what is happening in this area. Absolutely appreciate that. Dave, then.
So I just thought it was a really thoughtful, comprehensive paper. So thank you. I think really good stuff. And happy to have this discussion kind of separately because it might just be me. But I reread the Valdo Callaghan and issue with Not Healthcare, which was another report last week, and you reference monitoring of those people that fall off the radar. Yeah. And I'd just be really keen because I think that was one of the big points of criticism. They didn't know. They didn't know they'd fallen off the radar. Do we know today who has fallen off the radar? Is the question, but I'm happy to just chat about it afterwards. That's not for everybody.
Yeah, thank you, Dave. That's it. Yeah, thank you for reading that as well. Kathy, followed by Rachel.
So just to endorse that, because I think I sat in a room somewhere and I asked about that, like when does not self-care time, and that came out. So I think that again is still a really important question. I think this report is really useful. It's good to know that, although it will come here annually, it goes into the quality committee. But I don't know, I feel that I'd certainly like that oversight as a midterm thing. In the audit and risk committee, we often have sort of annual cycles for things of assurance, but we get a mid-year sort of oversight there. And I get that's coming to quality. So this is quite, I think, a really important issue. So the key thing that I wanted to ask about was the time taken and the time involved between when some of these were like, May 23, September 24, and the time to sort of get through. So obviously I don't understand all that chronology, so I'm happy to take that bit offline, but just on the face of it, I'm thinking, should it be quicker, or is there a reason it's as it is?
I mean, that is if you'll agree with me.
I'll respond.
then we can, I mean, if Dermot could take that offline with you and give you a complete breakdown of the actual timescales and the way.
Well, that understanding of the.
Sorry,
Yeah.
the reasons for that has been to the board on 3 separate occasions, so I'm slightly confused by the question, but
No,
we can happily pick that up somewhere.
Yeah,
It has
we
been
can-
in the board.
Yeah, we pick it up. I mean, if Kathy is, needs that timeline, then Dermot will. That's okay. Thanks, Kathy. And Rachel?
Yeah, just 3 quick points. One, I think you would have probably come on to it in terms of the regs, September 2024. So really keen to understand about that, but we can take that offline. My second point was around, I understand about the learning half days. I suppose it's that question about when somebody joins the trust, or how do we set the culture in terms of making sure that they're aware of what's happened and how it doesn't happen again. So I think that very much links to the people learning plan, etc. And then my third question was just around all the national reports that we've had over many years in terms of learning disabilities and how we are embedding that within a trust. Also how we advocate for people with learning disabilities to go outside of the trust, and that contact reflecting on that patient story, for example, we had when we were at Bath.
Yeah.
So I almost feel that this is of real interest, and perhaps a separate session we can unpick it.
That might be a decent idea, Rachel, actually. That's, really helpful. Thank you. I think, I mean, at least if Toby doesn't need it, we can bring that into one of the NED sessions and ask Dermot to reappear, as he did not so long ago. We had a great time, but we could do that. I mean, we could have a specific NED session on this, Dermot, if you would.
I'm happy to.
Yeah, no, I think I would just get our brings us up.
Can I just go in again? I'll do that next
Yeah.
time.
Sorry, Marie. Yeah.
Just if I could join, if it's not a NED session and there's a discussion you have around engagement, disengagement, I'd be really interested in that, because that was one of the points that I was wanting to discuss. And also, you know, what you could do on the best policies in the world. But for example, you talked about information sharing with primary care. Am I right in thinking that's subject to patient consent now? If we know that disengagement can be a symptom of an illness, then I just wonder how you get around that. So I would be interested in following.
Let's invite Dermot to a NED session. I mean, we've got to make the NED sessions more informative and rather than just us all getting on screen and chatting. So I will invite you back, Dermot, and you can do a session on this. Toby.
So first of all, nobody's told us to make this annual. We've chosen to have this report. So to be really explicit, this is not a report comes because we've been told to do it. It's not a report the board has ever seen before. We're doing it because it's important. It is substantially more important than the Greater Manchester or Calicane investigations because it draws on a far larger group of cases. So it is, it feels like an important thing. So I think whether it's in the NED session or in an informal part of the board, I would welcome the opportunity to really mine this because I think it's very, very valuable. And I think the reality is these things will happen again. And therefore we need to understand that happening. Second point, this is an early entrant in my best wallpaper of the year award, Dermot, so thank you for that. And genuinely, I think it's a fascinating paper. The prize is to be confirmed, but we'll see Steve twinkling. The final point I wanted to make, I really do think 9.1 is very, very important. Now, Phil Gowland's obviously on the hook for the implementation arrangements around policies. Jude's done a lot of work on actually making our policies intelligible and maybe having them in easy read version and so on. So if I was going to guide the board towards one thing in here to focus on, it probably wouldn't be the greens and ambers in the 2 PFDs, which in other places are quite well cited on. It would be in a year or so's time to start better understand the policies that we're claiming apply. That feels like a really fundamental part of our organisational shift. And just to remind people, we've said that staff will have to retain employment here, have an appraisal, do their mask training, which is possibly a questionable value, and make sure they've read the policies. It obviously means the policies have to be read. So I would really direct a bit of energy at paragraph 9.1, recognising the energy will be enhanced by the coffee.
I'm going to annoy Carleen and break for coffee before she presents. Steve and then Joe, then we're done.
Yeah, just a second Toby's point that I think this is a fantastic paper, Dermot, so well done on presenting and the way you presented it here at board. I think it's important for board to have context that in England and Wales, on average, there are 35,000 coroner's inquests in a year period, 35,000, of which then the coroner writes to all health bodies around 500 times. So important context. I think the increase that we're seeing and the delay, just alluded to Kathy's point, is post-COVID. So there's been a backlog of people going through inquests as a result of some of the challenges that COVID presented. I think just in terms of joining up the dots and an important conversation to have, and you touched on it, Dermot, around Promise 19 and that, us ending our spare replacements. So this stems back to the conversation and Sarah brought to the table around the closure of 136 suites. Richard quite rightly articulating that actually we close because what we won't do is admit somebody out of area. And so what we've done is we've looked at the closure of a 136 suite as a potential negative, but actually what we have stopped is somebody potentially being admitted to Bristol, or in the case of, for example, Shazida Khan, who was a Manchester patient who was admitted to Bristol. Coroner subsequently concluded that her death was unavoidable as a result of her out of area admission, because a multitude of factors which we've articulated and I won't rehearse here, but predominantly linked to computer systems not being joined up, family not being able to visit, and Shazida not having any Section 17 leave in a local area that she knows. So I think it's important just to bring that context in terms of we look at intrinsically linked things. So we do then put more pressure on our inpatient services by, for example, using a Section 136 bed, but we don't then monitor the avoidable harm and just making a nod to that actually somebody isn't going out of area as a result of that. But we may look at the harm that comes as a result of that person as a negative being admitted locally, but actually would potentially save somebody's life. And I just want board to remember that.
Yeah, thank you, Steve. Very important. Thanks. Joe, last one.
Yeah, I mean, just around the eating disorders, really, to Dermot and Toby, I think we've had some challenging cases over the years that really challenge systems, hence the work of the Joint Committee, and really great to have the investment moving into the Mead pathway, which will support patients when they're admitted to the acute trust. I guess at early days, but question to Toby and Dermot around the ask that we're going to make of the acute trusts as a quid pro quo.
Yeah.
Do we think that's going to be fulfilled?
Yes, two positive things to say then, given that I was quite downbeat in answer to Jude's question much earlier about mental health spend. I can confirm that the ICB still have the Mead investment. Some of the Mead investments coming from us, some of the Mead investments coming from the ICB. That is still in their plan for next year. So that's the little candle that's, yeah, good. I have had responses from all three acute trusts. They're all positive with varying degrees of precision. So I think the answer to your question is yes, but I think there's some work to do over the next 4 to 6 weeks to establish that they really realise we mean it, as opposed to sending nice letters on letterhead saying what to say. But yeah, it's upbeat, Jim. It's upbeat.
Thank you, Richard. Very quick.
Yeah, it's just, and not to blow smoke up Toby's bottom too much, but I suppose it's in the papers, but Toby has diligently gone back to region about the planning, the lack of planning, support around eating disorders and dementia. So there's certainly a bigger, wider national gap around that as well, which we're pushing back. So I just think the context is important as well.
Absolutely. And thank you, everybody. And thank you to Dermot for what is a fascinating report. For all sorts of reasons, and I don't need to tell you, this is hugely important. And we agree that we bring this back. It is our decision to bring it back annually. So and obviously, Quality Committee will be much more involved, as Richard has outlined. So I think if we can agree those, then we can receive the report. We will pick you up on that, Dermot. We will. I mean, obviously, non-execs need to understand this. We're not clinicians. It's not something we do daily, but it's important that we have that detail. So we'll invite Dermot back, and we can receive the report. what I'm going to do is I'm going to give you 10 minutes for coffee, bring you back and take Carlene's report on training needs analysis for all sorts of reasons that you need to finish this forward by 4 o'clock this afternoon. So I'm going to have to drag time back from now on, please. But right now, comfort break. Analysis paper at item 16.
Apologies, we were just discussing a wobbly table. And that distracted me slightly. A very important paper in front of us here today. So just as a reminder to colleagues, and you don't need a reminder, but I am going to reiterate it, our workforce are our most precious commodity. So the training needs analysis focused on their development for coming years to ensure we don't have a static workforce from a training perspective. So I'll take the paper as read. I am very conscious of time, but just to draw out some of the key points. So from a training needs analysis perspective and from a management perspective, whilst we have different funding streams coming into the organisation, from an RDaSH perspective, we have one collective training budget, one collective training pot. Whilst we maintain the fidelity of the different funding streams, we manage that as one collective pot across the organisation. It links to Promise 24 and to expand our educational offer. You'll recall at various different board committees, we focused on the apprenticeship levy and the increase of the apprenticeship levy spend. This is our CPD, continuous professional development, and how we support our colleagues. So I think it's fair to say it's been a very interesting journey over the past couple of years. Historically, have we had a trust-wide training needs analysis? No, we haven't. We started that journey more so last year, and it's been a development process, very iterative, taking the learnings as the paper described from last year into this year, and also some learnings going into the following year's TNA and some diarisation and some scheduling. I'm pleased to share, though, the training needs analysis that's in front of us today and going to education and learning in February for the prioritisation covers all of our 23 directorates. So spans the organisation and spans all of our different staff groups. We've taken a pyramid approach, looking at the organisation, the team and role and the individual. I'll draw your attention to the change in position though. Under section 4 and primarily section 4.11 onwards, whilst we've still got those traditional training courses that you would have seen a number of years ago, so a postgraduate qualification, a master's qualification, we've still got those in there, but it's a very different TNA that we are exploring and looking to finalise this year. So it focuses on our needs going into next year and future years to develop the workforce. We've touched on digital literacy and AI. How do we upskill our workforce? Touched on some of the challenges we've had in previous discussions from a mental health perspective. How do we support our inpatient colleagues who work in mental health, for deteriorating patients, physical health skills observations? How do we cross-skill across the workforce? So a real commitment there. Also, we should be very proud of our investment in training over the year. So we've touched on LDO, leadership development offer at previous years, and a significant investment. I'm pleased to share, as reported in the papers here and other papers, as part of our investment fund as an organisation, we've committed a further £75,000 to grow our training needs analysis. Part of that is on the back of the work we've done where the demands and the requests across the organisation exceed our budget allocation. So we're not saying to managers and to our colleagues, no, we need to deliver within the financial envelope. We've grown the financial envelope. So there's some of the main points on the TNA, but then referencing Sarah's feedback we've had on the outbrief reports earlier today, and Toby's referencing earlier on Dermot's paper, section 9.1, a change in landscape that we're going to have for some of our maths training. We've focused on a small number of maths training courses to address some of the challenges that we've been working on that haven't necessarily had the success that we would have hoped. And you'll sit there and question and think, shouldn't have been that hard. And I think that's a fair reflection. It shouldn't have been that hard, but there's some further work we need to do alongside the overarching changes we're going to do that Toby referenced under 9.1 with the policies, MAST and the appraisal. So that's an overview of the paper. Let me pause there because I'm very conscious of time to facilitate the questions.
Thank you. And obviously the Trust's commitment to that budget, it's our only untouchable budget, and it's paramount. And this isn't red paper carry. It's not so much about processes. It's about the equity of what they're doing and making sure that this is trust-wide and delivers for the Trust. And at some point you can tell me why we need 4 truck drivers, but not now.
I'm doing that.
Questions, obviously, to Callan. Simon.
Just a comment. Having worked in a number of trusts, I think what we're doing is really impressive. You know, it's comprehensive, it's thorough, it's inclusive. And, you know, coming 8 weeks in, you know, this is a really impressive piece of work. And listening to the care groups and the directors within the care groups and the delivery views, you know, it's fully owned and it's understood. So, you know, yeah, really, really impressive bit of work.
Yeah, thank you. Jude.
I just want to compliment in terms of what Adam said and Adam a bit as well. I think it is not just that we've created the infrastructure now, but forward plans, and is also aligned with our policies and practices. But we've also created a momentum with our staff to value learning in a different way. And obviously education is only one part of learning because it's a more formal, often classroom based part, but you know, nonetheless a really essential part. And we do go beyond what's expected of us in terms of some of the parts that are given in, because we know it's the right thing to do. We also know that we've got people that go through journeys that aren't, particularly just in terms of nurses. And that's really important for a lot of our other promises that are connected to those that are specifically them. And it's very enabling to people. So it is to commend what Colin said, but to also stress the importance of having this structure in place, because it is part of the organisational planning as we go forward and forward planning round, not just something that happens as in.
Absolutely. I've got Rachel and Toby.
It's fine. I just wanted to praise the process. It's already been done.
Yeah, I'm looking there. It's good. Yeah. So behind all this good work, and I echo Simon's point about it being quite owned this year, there are still quite a few barriers, aren't there, that said we need to be open about those. I'd be interested generally in what you think the barriers are. But one of the barriers I observe is a continued deep-seated belief that there are separate pots for different things, and that I have to. So, what would you suggest we need to do to in the nicest possible way, deal with that? And I apologise if the question is elusive to people without the background, but it is palpably standing in the way of some people putting forward training propositions, that there is a belief that there's this pot for this group, this pot for this group, and there isn't a pot for forklift truck drivers or whatever it might be. So just help me with that, and then any other barriers, if you could.
So just to expand on some of the barriers so we have a wider awareness of the context of the question. So we've touched on the fidelity of the different funding streams that come in. Some individuals within the organisation, and I think it's fair for me to reflect as well, the training department have reinforced some of those funding streams. So we have to recognise that and own that we are addressing that. But for future years, it will be one budget that's available. What Colleagues have previously had to do is assign it to help with the national returns process. That shouldn't be a managerial responsibility. No. That's for us to manage with the data returns that we have to do to say, is it assigned to a nursing colleague? Is it assigned to an allied health professional colleague? Because under funding streams, a nursing colleague, the rule book, for want of a better phrase, tells us each nurse should have no more than £1,000 per annum as part of their CPD. So we need to manage that behind the scenes. So as next year's training needs analysis, there will be no organisational communication or spreadsheets or returns that have various different staff groups to stipulate. It's the funding pot that's available. We need to break down some of that barriers though, because some of that is a learned behaviour within some of our care groups and some of our backbone areas that historically haven't come forward. I think from a backbone perspective, because historically it was the SSLDF part, that was only a very small part in the region of about 50,000, which has grown slightly over the years. That has never covered our backbone corporate costs. This year, I'm really pleased to see a number of requests coming forward from corporate backbone. We have validated that it is a valid training requirement. We have worked that through.
We've got it. If we're going to have one, we better know how to use it. It's dead dangerous.
So a number of areas there. So we have addressed that in part, but culturally there's further work to do. I think as part of that as well, it's the sharing across the organisation. So historically, we've operated in silos, 23 directorates. Have we looked to cross-reference the training requests across the directorates to do a bulk purchase to deliver some of those economies of scale? No, we haven't. So that's been a barrier from a financial perspective. Another barrier has been the timing. We've done it very late in previous years, and it's come into the autumn where we've suddenly got this amount of money that remains available to spend. What is our demand? So we've done it much earlier this year to commission some of those courses going into April. One of the barriers is the release of our colleagues and the release to attend the training. So we've done some work on that. Given the challenges we've had that we've referenced for some of the mass training, have we overcome all of those barriers? Absolutely not. There's some further work we need to do. But given the commitment we've got within the directorates to facilitate that training, it feels as though this is viewed through an important lens and colleagues have a desire to attend. Do we have the same desire and willingness from a mass perspective? Not necessarily.
Thank you.
Thank you for using that. Julie. Just to add one thing to what Karen said as well. The funding model from NHS England is a very traditional one, and it arguably is not helpful and not applicable in terms of well-led and safe. So why I say that is that we've taken an approach to multi-professional leadership, which is advocated as much more safe. So what we do is we look across the professions of how we work together. So where we can, we commission teams to learn together. And that may be where there's expanded roles such as our non-medical prescribers and our medical prescribers. It may be things such as where our therapists work with other disciplines as well. So I think we are taking a more modernised approach, which really feeds into what well-led as well.
No, absolutely. Very proud of it. Yes, Rich.
Sorry, I'm just going to come back as well. One of the things we've been asked to look at in part in terms of the 10 measures is that equality data. So not just across care groups, but when we looked at the WDES and WRES, to make sure that all our staff are accessing that training opportunity.
Yeah, no, it's very thoughtful. Thank you. It's going to really make a difference, Aline, and I think that's an important thing that there is a single pot that staff have the quality, equity of access to that pot, that the training that we do and we support is tied into the direction of the trust and the strategy. And it's great stuff. So thank you for this. The recommendations are with us. It is a step change. I hope everybody recognises that around the table. So we can obviously consider the new training, but the recognising the improvements that we've been working towards, and we'll note the revised approach to masks. We're all very grateful. So can we agree to receive the report? Thank you. And big report today. So we've got Steve on CQC readiness, our self-assessment. So significant report, Steve. Previous we've looked at this a lot in time, but we'll get there. We'll look at it again. So thanks if you can kick us off.
Yeah, thanks, Chair, and thank you, Board. just remind board that this is the trilogy of papers that have been received, with the baton being handed over into the second paper that was authored and presented to board last year. It clearly demonstrates the progress, certainly on the 4 domains of safe, caring, effective and responsive, while there being a distinct separate paper that comes later in the agenda that Mr. Gowland will present. Our position of last year, you'll be reminded that there was certainly work to do, with some areas scoring less than requires improvement, and this was the journey on kind of getting to good. And I just want to bring that into context for the board and its members, in that this is not a small task. So we really launched this in January of last year. So this is kind of 12 months on from that journey, accepted that there was a baton pass from chief nurse to chief nurse in that intervening period. This means that we've reviewed it in excess of 350 pieces of evidence. So just want people to recognise the enormous amounts of input that has gone from the care groups. And we've seen this progress and gain traction really from the delivery reviews that Toby has spoken about, where we explored this and really tested it out. So of those 350 or so pieces of evidence, we've created it's a library, it's a suite, it's a vault that is accessible. We've provided consistency on what the evidence that is submitted into that library. And I think we've spoken in the lead up to board about actually how useful is that, and it is exceptionally useful because it talks to the change of culture that we're creating in getting CQC ready. Dave, you've spoken about CQC being an everyday event. Absolutely. And the evidence is then able to be pulled and shown to new people who move across directorates, but also kind of that consistency of this is how we do things around here. So summarising certainly some of the self-assessment where we've moved on. There are some that remain static. So across the kind of 338 quality statements, so there are 338 quality statements because we are looking at 26 statements, times that by 13 directorates. You can see why we've then got the 350 excess evidence documents to look at. So 12 remain as requires improvement. 66 since the last time have moved from RI to good, with safe overall still rated as requires improvement, and effective and caring and responsiveness moving to green. If we look at that across the 4 domains within directorates, we've seen 20 improvements. So that's improved in 20 of the directorates in the 4 domains, with the 3 that remain static that requires improvement, which are children's physical health responsive, North Links acute for both safe and responsive. Notably, you'll see that there is a sea of green for physical health in both of their directorates for long-term conditions in community and rehabilitation. I'll pause, Chair, because I think there'll be a number of questions around testing this out and kind of the next and forward steps. I think it's really important before the forward looks at consolidation and where we're going to close the remaining RI areas and how we're going to get those to good, mainly in the responsive and safe domain.
Thank you.
Okay.
I mean, can we just, obviously, before this matter closes, we need to agree the process for inspecting evidence files between March and June, and we will return to re-examine this in July. So we've got to get that out of this report as a decision by the end. That's how we're going to do that. So Joe, Sarah, switch glasses, Dave, Richard, did I see your hand up? Give me just hang on a minute. So Joe, Sarah, Dave, Richard, Rachel. Yep, Joe, Hunter.
Yeah, thanks, Steve. Really good report. I think it's good to see the shift and improvement in the robustness of the work that's been done, both in the report but in the delivery reviews as well, and the way that the care groups talk about their evidence and to link it to the ratings. That's really good to see. I've got two questions. How much of the care groups fed into this, their feedback from care opinions of the patient experience, and where's that coming in? And then the second one, really, you've mentioned a number of care groups have mentioned about needing to embed Dialogue Plus. It's mentioned in Toby's report as well. Perhaps a wider question of how confident are we with that embeddedness going forward, and how we'll test that out.
And we'll take a couple, Steve, and then I'll bring you back. We'll do people in little blocks. Sarah, please.
Thanks, Kath. Again, you've got a really good paper. It's great to see it. Very informative, very short pages, really. So I suppose my question was really around testing the evidence. So I noticed that the reviews, there's a bit of testing going on there in terms of people submitting, but I'm just wondering how much of the evidence, judgments of the evidence, is subjective and how much of it is objective, because you get that hawk and dove thing, don't you? And do we have externals from time to time that will come in and dip test some of this, just to, just to have that sort of hawkish view, if that's what's required? Because you could end up with a hawkish panel. I know this is every day, but you still have a visit. You could end up with a hawkish panel of that.
So thank you. I'll take Dave, and then you can answer. Then I'll take up else. Dave.
And I guess it's a build from where you're on the objective subjective, Steve, because the Rotherham caught my eye because there's clearly a number of improvements there and substantive kind of comments that say actually it has improved, and yet the eye is often drawn in quality committee or around data around Rotherham often stands out as an outliner, not necessarily for the best reasons. So it was both encouraging to see that progress, and I'm still left with the that kind of goes against some of the things. And maybe the stuff that's in my head is old, and this is now an updated and new version. So I need to recalibrate my own mind.
Thank you, Dave. Right, we'll come back to the three people that haven't seen. Steve.
Okay, yeah, thanks, Joe. So care opinion absolutely is in the evidence vault. So that is a clear reason why we've certainly seen an increase in community, particularly because of the way that we've embedded care opinion. More work to do in acute, absolutely. Dialogue is one of the factors, if you read through, that's still where we need to improve, but we're aware of that and there is a plan. So that's one of the areas we'll certainly be consolidating on when we move from, or attempt to move from RI to good in a number of those areas. Absolutely, Sarah. So peer reviews. So firstly, peer reviews are testing those out. So I would encourage NEDs and our governors who participate on the peer reviews to ask these questions and use this almost as a crib sheet aside of that. And then also the CQC readiness meeting where there is peer scrutiny. So what we're asking is that this is a multi-professional leadership that tests it out. So it's not a matron that goes to another matron's area to test it out, but maybe it is a psychologist, because this is everybody's business, and that's where we've seen the embedding of the CQC in all of the team meetings. So yeah, but I take your point around actually, is there something further that perhaps we need to do around that? Dave, of course, eagle-eyed and well spotted. So these are at a point in time. Of course, CQC will come in at a point in time as well. So they have already come and assessed Rotherham in terms of the acute mental health and given a snapshot. What I will say is there is further detail further down which articulates some of the concerns. I mean, we know about them and we're talking about them. Whether they teeter on RI and good is the challenge, isn't it? Because of course, once this goes out to print and it's dry, things can fluctuate and change, but the importance is how we describe the journey so it's consistent. So at times there may be that on a weekly or monthly basis, actually things have deteriorated in terms of performance, but we're all on the train, on the CQC readiness train, and know what needs to be done.
Thank you. Can I then take Richard, Rachel and Toby, and then we'll bring you back.
Thank you, Chair. Yeah, I think it's probably been covered because I suppose my question acknowledged a huge amount of work in this. And it's helpful for board to have that line of sight. I suppose Steve touched on how else, has he got thoughts of how as board might want to assure or not assure themselves in relation to this? And picked up in terms of the peer review. Equally, Rotherham is mentioned as an outlier. So I was counting the yellow squares for the acute. I think that probably does reflect the position, and we need to sort of test out between the acute and, in fact, it's the only one with a downward arrow. But I do think those are the points of triangulation against this. So I think it's really the final question for me is just a bit about to Steve, but as Carling's earlier point around the 4 weeks was a really interesting point about we might celebrate these things. However, when CQC lands, they won't come anywhere near us. They might look at this in terms of the well-led, but they'll speak to staff on the ground. So if we're like very positive about 4 weeks, but they speak to member staff that they're bloody making us doing it. So there is a vulnerability, which means this isn't not the case, but CQC will speak to staff who, if they're feeling aggrieved because we're going through a service change or whatever, it's just a vulnerability that we collectively need to think about, as well as how we collectively test out and reassure ourselves on this data.
Absolutely, Richard. Just a very, very good point. Thank you. Rachel.
Yeah, really good report. And my questions were around, that subjectiveness, because if we all were asked to rate something, we'd probably all come up with a different, but Sarah's covered that. I suppose my other question then, Steve, was around that. Are we focusing enough on the requires improvement? And I think because it's a board report, probably the detail isn't in there in terms of how that focus is taking place. So I just wasn't able to answer that one. So it'd be useful to understand almost the minute detail about the time scale and the programme, etc., but probably offline. And then I suppose the focus has got to be on requires improvement, but then how do we keep the good was my other question.
Sorry. Thanks, Steve. I won't repeat everyone's acknowledgement of the work, and obviously there's a hell of a lot of work ahead, and we do need to spend time in those evidence vaults collectively, don't we? I want to focus on the translation between table 2, which is our way of looking at the world, and table 1, which is the CQC's way of looking at the world, acknowledging to your point that this isn't about CQC. So I get that. I think that's helpful. So just to draw people's attention to, there's 2 services where we are RI, I think you said RI, that date from a while ago, as opposed to the RI on our acute wards, which clearly is relatively recent. One of those is community health services for adults. One is community-based mental health services for adults of working age. So I just want to use those 2 areas to translate between the table, because what the table 2 is telling me is broadly in community health services for adults, we've gone from RI to good. That's practically what it's telling me. And then it's telling me that for community-based mental health services, we've gone from RI to good. So here's my question. I am pretty persuaded of the first of those 2 things. I am pretty persuaded from what I can see that community health services for adults should be rated as good. I am much less persuaded that community-based mental health services for working age adults should be rated as good. But table 2 tells me largely that I should think it is. So could you help me with that? Do we really feel right now that community mental health services for adults should be considered to be good? And if you disagree with me about community health services for adults, tell me. Thanks.
Back to Steve. There's a block of questions.
Okay, Richard, brilliant. Yeah, so I think we are, of course, displaying our public waiting lists, and that's a massive transition. So not only should our staff know about it, everybody in Rotherham, Doncaster and Northling should know when you refer to RDaSH, the GP can say you will be seen because you're being referred to this service, but log online forward. So I think we've got to share that not only with our public, but with our staff. Absolutely. Point taken, and how we communicate that, I think, is a collective responsibility. I think the CQC, of course, within that, they always allow for a degree of negativity and disgruntlement within an organisation. I'm not counting.
I was going to say they're not very good at that, Steve.
No, but they certainly talk about that.
They talk about it.
Yes.
Yeah.
But I'm not saying that we should hang our hat on that. But absolutely, you are right around how we celebrate these successes. Rachel, I think your testing of assurance and the detail is linked to your subjectiveness, which Sarah kind of picked on. And I think the important part of this is Q1 forward plan, where NEDs and similarly execs will be testing this out, would be my recommendation.
Yes.
So I want you to come and say, Steve, you set this in board, let's go into the vault, let's look at it, let's go and talk to Doris, who's on Hazel ward, and then so not only see it, but hear it as well and experience it. So I think that's the forward plan, which I hope that answers your question. And then you asked about sustainability. So I think a number of the reports, so if we take Dr. Sinclair's report on PFDs, that talks about the policy improvements and the learning and the sustainability of learning from some of our serious incidents. So that is an example of how we sustain this learning culture, the work that Carleen and Dr. Graham have done around education and learning and how we do our learning half days. They all feature as a part of how we look to sustain this rather than it being just a one-off event. So CQC readiness is not, we haven't come and said, we're going to, this is how great we are. We're following it through and continuously. It's that kind of Hawthorne effect of applying the scrutiny all the time to it. I think, Toby, your point is really well made, because I think also not only conversely have we gone up, we've also gone down. So some of our areas, of course, you'll see are outstanding and they've gone down to good. But given that you're focused on where we've gone from RI in our previous CQC inspection to self-rating as good, particularly in, I won't labour the point on physical health, but we know that they have improved significantly.
No, I buy that. That's not the one I don't buy.
No. So if we look at mental health, for example, we've heard in the previous kind of 72 hours around the improvements that have been made for the 4-week wait, particularly. That is a significant improvement around allocations and appointments being sent. So in terms of effectiveness and responsiveness, absolutely, in providing a safe service. We know there are areas of work that we need to do, and that Joe picked up on that around dialogue. So we know that's a real key focus. Whether that would put us into requires improvement, Toby, I feel that the vault and the evidence that we've seen and some of the metrics that we monitor, for example, through IQPR, is why we've kind of improved that to good. I can talk specifically amongst the domains for each if you want that level of detail here.
Help me with, it's okay, Jay. Help me with, so we have a significant number of people who do not have an up-to-date care. That is going to be different in a few weeks' time, and I get that. So if we're having this conversation in April or May, I might not be pushing my point. But we have that. Until very, very recently, we had a sizable number of unallocated patients to community teams. And in one of our care groups, we still have a very sizable number of unallocated patients. You won't be surprised to find that's one of them, given the gist of the conversation. Which domain would the CQC look at those two things under?
I'm going to give you the details of it.
Because I suppose it's that I'm finding surprising that isn't RI, if I'm honest. And to be clear, I'm not in any way trying to invalidate the whole paper or the table. This is a very specific thing, but it is a big part of the services we provide.
Absolutely. Just going to go through the evidence. Is that okay, Toby? And then respond so I don't. So if we take Rotherham Community.
Yeah, let's do that. Let's just use that as an example.
So amongst, across the 28 questions that we ask and the evidence that we look to, it has gone from RI to good in IPC.
Yeah.
So we've done that through matron walk rounds, inspecting, various elements of IPC. Safe and effective remains as RI. So if you look at the specific domain, so based on what you've just said, you would expect that to be in RI.
Yeah, okay. And is that the only place that those issues appear? I mean, that's fine. I mean, you're the expert on the detail. If it literally gets distilled into that one thing, then I understand why we are where we are.
So supporting people to live healthier lives remains at RI for that very reason as well. Okay. And that's, I mean, when I look at that, it's around the physical health clinics that are providing more work to do on the SMI physical health clinics, and also the care planning features as part of that supporting. So So, but then if you think about overall, so within that domain, there are more greens.
Yeah, yeah.
But we've got a clear RI for those two elements.
Does that override it?
It's a real, it's
You see what I mean?
it's a judgment call, Toby.
Yeah, okay.
And I'm not saying it's right.
No, I'm happy to leave it there. It's really helpful. I hope not a waste of the rest of the board's time me prosecuting this. That's really helpful. But I think for me, then it pivots on the override question. Do we think that's such a significant thing that an excitable inspector who tends towards RI will go, don't care about the other 5. That's such a thing. That's RI. Or indeed, Carlene Richards' point about the staff would say it's rubbish around here because we can't even do this. And I don't feel safe.
Yeah, go on, Steve.
No, and I think that's really important. And you haven't led the witness in your prosecution, but really clearly, Toby, a single oven that isn't used daily in an acute hospital, given that all our other ovens when we prepare meals and are clean, the one where a physio accessed it and hadn't cleaned it to the level or the domestics hadn't, meant that we rated as safe along with other things, but it was that particular. So I can't negate that the point that you made, Toby, that an over-interested inspector may focus on one very specific thing, and as such our rating does not marry up with this. So I don't want the board to feel that would then negate the work that we've undertaken and we're giving false assurance, but it is that pivotal.
Okay, yeah, really helpful. Thank you.
Thank you. Quickly, Richard. And
Yeah, I think this is a really helpful debate, and I suppose in fact, you used to do a setup meeting with the CQC at the beginning, where what they want to see as well, ladies, this is what we're doing brilliantly at, this is where our issues are, and this is what we're doing about it. So within that as Toby and Steve work out, these bits are green, these bits are the yellow bits, and it depends on nuance. But I think there's a subject about whether it's RI or green, and that's for us as a trustee.
And I thought the point we were just going to come to is in their new methodology, you don't do that anymore. And that's a real problem. And certainly I experienced where I was chief exec before a palpable difference arising from that, because you effectively didn't get a chance to demonstrate your insight prior to the process. So we just need to think about how we address exactly that point.
Yeah, absolutely. So thank you, Steve. It was a huge amount. It is a huge amount. That's an industry in itself.
Absolutely.
But we do need, just very quickly, because we need to agree it here, the process for inspecting evidence between March and June. So I know you spoke to Rachel about looking at the vault, checking that against the reality on the ward, and I think just lay out the process so that we know what we're agreeing to between March and June.
Sure. Chairman, we've extended the invite for you to attend the CQC readiness to experience the level of challenge in the scrutiny. So I would extend that out in terms of attendance. I think non-executive directors and execs would gain a lot from that. But I think the challenge to the board here for me is that as part of the peer reviews, those being scheduled, that people use this paper and talk to it as well and ask those questions whilst out on those inspections. And I think finally, if I can, or if non-exec directors would like to contact me, we can then arrange an appointment to go through that with the team, with myself, and really interrogate that detail.
Sounds like another meeting.
Can we add one more then? So we have an April timeout together. So if we were to devote half of the April timeout to scrutinising the vault, Steve, I think it gives you fair warning. If that's okay, does that work? Not instead of the things you mentioned, because I think they all serve different purposes. But if we go muck about in the vault for half a day on the April timeout, I think that probably gives us the useful use of time.
Sort of Channel 4 game. Go muck about in the vault.
That's not far.
Says the chair of quality committee. Let's not have that in the minutes. Yeah.
Thank you.
Just on the back of that about peer review, whether there's a conversation with Laura about maybe tweaking the template we worked.
That's great. Thank you, Richard. If we could leave that with you, Steve, that would be useful. Can we therefore we've discussed it very well, and we will agree the process between May and June, and we'll take that into the board time out in April. Yeah. Thank you. Thanks very much. You're a brilliant board because we're back on time. Thank you. We come to the item 18, which is the Euro diversity weights update and survey. So questions only, please, to kick us off. We do need to pin down what we're asking the risk management to do in here. So you've got the paper. It's hugely important. We're proud of our 4-week weights. This one is the outstanding one. There are particular problems in North Lincolnshire that we know, but questions to Toby's paper, please. Maria.
I suppose this links with kind of like the previous paper. I mean, acknowledging that this is a national challenge, and I don't think any trust that I'm aware of has cracked this kind of across the country. But just thinking about kind of the CQC ratings for the Physical Health and Neurodiversity Directorate, kind of noting that kind of it's kind of recognised that there's further work to be done in terms of embedding care plans, risk assessments and safety planning as part of that work, acknowledging these long waits that we have come upwards of 2 years. How confident are we that that directorate is safe and responsive? Appreciating that there's all sorts of aspects that they are doing well, but I suppose it comes to some of this kind of override issue.
Let's go to the next question. Sorry, I think I meant to be bundling questions.
We can bundle questions if you.
I thought we were going to take all the questions and then I was going to respond. That was what we agreed. So,
Maria, come in.
Yeah, I just wondered around the DNA rates for ADHD appointments. I wondered if you took any deep on that and you knew what potential problem was there, whether any protected characteristics and what potential solutions were for that. But then I was also really interested in the data around 8,000 people waiting broken into 6,000 for ADHD, 2,000 for autism, and that took me by surprise. So I wonder if that's a national trend. And then I wondered about the potential splitting of services, whether it will ultimately then will it duplicate work, because quite often these conditions are co-occurring. So is there going to be some people coming back round into different systems, and what's the impact of the trust? What's the impact of the patients?
Thank you. Other questions?
I'll take Dave and then you can answer the other as well.
So completely agree with the approach. It was just my ignorance around the level of support and service we can provide people pre-diagnosis and post-diagnosis using talking therapies. And I was trying to find out, do we do that? And does that happen nationally? And it seems that it can be appropriate with some tweaking, but I don't know whether we do that. Or even would want to do that. But it struck me, if you're waiting for a long time, I think you've used it before, so a really long wait service like that isn't a service. So what is it we can do constructively during that interim?
Waiting well agenda.
Yes. But it might not be there, not the right answer.
Right, I'll go with those, and I've got Pauline and
Richard.
Richard.
Sorry? You want me to answer those now?
Yeah.
Okay, all right. Right, okay, so sorry, the number of those is sort of outside the scope of the paper. So on the CQC isn't going to come and assess the physical health and neurodiversity as a care group or as a service. It's going to address by service. I think in truth, we don't yet know how the CQC will approach CQC and neurodiversity services. And I think the most practical thing to say is that when we get to the right moment in our relationship management meetings that you and I attend with other colleagues around this table, we ought to push them a little to tell us that. We've obviously debated how we should self-evaluate our wait times. And I think we concluded that you could be good even if you had longer than 4-week waits. But we simultaneously concluded that good was less than 80. Which clearly we're not at. That isn't quite reflected in some of the documentation on the earlier paper. But I think the most practical thing is we sit and talk to the CQC about how they wish to approach this. My instinct is that that should properly then relate back to Dave's question about support that we provide. that there are models of support, but I'd be a bit cautious about us giving an answer here that's terribly reassuring, because I see quite a lot of patient complaints that would suggest that despite our offer, that isn't necessarily accessible. So what I'd rather do is to consider that with colleagues, Dave, and maybe pop a note round in terms of, okay, what are we actually doing, and are we actually doing it consistently, and what are we not doing? But clearly the logic of the paper is that specifically to adults, which is the main focus of the paper for today, we don't have a backlog solution, and we don't have an ICB that's remotely interested in working with us to find a backlog solution, and that's a debate that I am having with them, particularly if we go down the route that I am pushing in this paper and in other places, of potentially for people who are awaiting an autism diagnosis. And I hear the point about potentially being honest with those people that the reality is that here is the support and please access it, and that there isn't an NHS diagnosis service locally. Then your point's even more made than erasing it. I think we want to give the ICB a solution to the ADHD issue, which is what some of the recommendations are about, albeit it would be over 2 or 3 years, and for want of a better term, put them in a place where they have to explicitly turn it down. In national planning terms, there is quite a focus on neurodiversity for kids. There is a silence on neurodiversity for adults, despite the economic and employment and other life consequences. But I do think if we can get to the point where we've got a proposition we could actually transact, often these things are about timing, aren't they? Yeah, there's a moment. Now, is there a moment that amounts to £4.5 million? I don't know. But we're willing, this paper says we're willing to give it one more go. There's a point based about DNA rates, right? So I think I want to compare our DNA rates to other services to understand to what extent I have to accept that this is a function of a client group, a set of behaviours. On the other hand, our administrative processes historically are the kind of administrative processes that give rise to high DNA rates. You've waited 3 years, but could I see you, in a couple of weeks' time? That doesn't really work. So one of the things we're moving to, and will be better with this in children's than in adults in short order, is to be able to be really explicit with people when they're going to be seen from very early. Now, that might be really explicit, as in you will be seen in Q2 of 27, 28, because you wouldn't communicate it like that. But that's where I think we're headed, to be clear with people, not that there's a really long way, but that you are likely to be seen in this time frame. And I think that then informs, creates a better mutuality with the patients than we currently have. Part of that requires us, and the paper hints at this, and the guys have done this, is the separation of different waiting groups. So we've got people waiting for treatment. We've got people who are waiting for treatment but actually started treatment somewhere else. We've got people waiting for diagnosis. And I think we'll get a clearer stream of service when we've got those things really clearly separated. And what is implied with what's committed to in there about April 26 is to be really clear about how we've separated those things and stuff. Now, the care group team are clear with me that they have a route to get to 173 assessments per month and still manage some of the treatment backlogs. Clearly, that's what I said in September vis-a-vis January, and for a set of good reasons, we didn't get there. So the intention is to be there in April. So what that would mean is the backlog stops growing while we work out a solution to the backlog. So that's where we think we are.
Thank you. Pauline and Richard. Pauline.
Yeah, I think you may have answered part of mine, but recognise we've got no backlog plan, we've got a funding issue. So on the funding, I know you're saying the ICB not getting the interest and priority. Can we go beyond that? Can we go to region? Where can we, anywhere else we could be exploring, given it's a planning round? I'm probably
This is
not.
a bit of
but
a
I'm
Jack
just-
Nicholson moment, isn't it? Emily, can you handle the truth? Go on, what's your question? Go
The
on.
other question was, I think again, you partly answered, but
Yeah.
what is the communication and the clarity we're providing to the patients, therefore, to help them and enable them to make some choices? If they can't
Yeah.
come to the NHS and they need to go private or things, to get an informed choice.
Yeah. So I think what I genuinely can't recall if it's explicit in this paper or is it a different thing, is that if we reach the point at the end of March where there is no credible external interest in moving this forward, then it would seem ethical to write to our entire waiting list setting the position out. I've referenced the autism point in the paper, so that people are really clear. If you recall, Glyn Butcher at previous board meetings has raised how clear is it? That is then confounded by the fact there are slightly different right to choose processes in different boroughs. The one in Rotherham is particularly labyrinthine. So that's what we would need to do. I think what we're trying to achieve is to put right to choose out of business by what's described in this paper as a level playing field. It's not a typo, it's just a play on words. I think that there is a paper, the ICB, that would approve that. It doesn't go as far as I would like it to go, but I credit the ICB with the fact they've gone there. How that then connects to this paper is whether that comes with a cap or not. So if we get to a tariff regime, and the messages get on with it, and we're trying to put the right to choose providers out of business, then maybe we can go further than is here. We're not just going to be able to go as far as dealing with £4.5 million worth of work without anybody stopping us. Does that make sense? But I think, so maybe the answer to your kind of escalation question, which I probably answered with my already, is I think the way to play that is to be explicit with the public. But if your question is above the ICB, is there any interest in the failure to resolve this? No.
It was both.
Categorically, there is not. I think that obviously Secretary of State has his commissioned review of these things. Whether that interest will change after that has finished, and one assumes that the two professors involved will confirm that this isn't a social media trend, it's a legitimate diagnosis, maybe that will help. Albeit, I think if we can produce a solution, Pauline, then there's always a chance people want to buy into success. But right now for this team, I want to get to a point where they're able to be stable month on month.
Yeah.
I think that would be powerful, because what our conversation overlooks, and that's not meant critically, is the amount of progress that Cora and the team have achieved over the last 6 months. And I know you get that, but it really is quite substantial. And if that doesn't come across, then that's poor drafting on my part.
But potential of that to be a platform to offer this solution, because we've got a track record already.
I think that's right.
Yeah.
I think that's right. Recognising that one of the dynamics, and this goes back to the 4-week thing, is that if other providers are not solving this issue, sometimes the NHS is less interested than you would want in having an outlier who does solve the issue. I think it'd be fair to say, talk about the private board. Kath and I talked with regional team about 4 weeks for quite a while, and it was a bit disconcerting how disinterested people were. I would put some of that down to the uncomfortableness of comparison. Jude used the phrase in a different place, the shame that arises from some of these things, and I think that's very astute.
We took a thing from taking a snapshot at 2:30 on a Friday or something. Whatever objective.
Maybe.
Richard, and then we'll come to.
Two specific points, Toby. You talked about meeting demand with 173 assessments. Is there a danger that actually, as we improve demand,
Yes, there is.
And the second one was great. We're getting through, we're making diagnostic decisions, and then we move on to prescribing. And yet you've got the block with shared care and primary care. Is that solution visible?
So the working group that we co-chaired and that others have on the table contributed to has a holistic solution which includes that. The paper the ICB has chosen to consider separates elements of that solution, so that I'm being very fair to them, I suppose. That shared care model would come through the LES, and there is some nervousness that I can understand from treating just this bit of the LES separate to the rest of the LES. If that introduces a 2 or 3 month delay, I think that's handleable. If it introduces a sort of long grass GP contract conversation, then I think it's more problematic. So I think we have got some element of a holistic solution, Richard, but you're absolutely right. One of the risks to what we're describing is not being able to handle the shared care. That's more of an issue for kids than for adults, but it is definitely an issue for us, particularly in Rotherham, where again there are different GP arrangements around shared care than in the rest of the district.
Thank you.
Kathy, if that's everybody's questions, can I add one thing in terms, because you made reference to those papers about adults in the introduction, and then in paragraph 4.2, there is reference to the appalling situation described in our slides for region as unsafe, whereby young people are diagnosed in North Lincolnshire and then put into limbo where they can't receive the treatment that they are, or the support that they are recommended to have. So as of last night, the ICB and ourselves, the ICB have confirmed their intention to invest in that from April the 1st. Indeed, they're very keen to have that agreement. We are a 6-figure rather than a 7-figure number apart. And I think Simon and I have sent them some terms of trade that I think they're going to agree to. And then over the course of the next week, they're left to consider whether they can increase their offer a little bit. But I think that's as positive as we've ever been, that we will get to a place. We will obviously then need to recruit, and one of the more challenging bits of our terms of trade is they have to offer us a 3-year deal, because I'm not having another North Lincolnshire arrangement where we go and recruit a large number of staff on a 1-year contract. So I think that's encouraging. They also encouragingly are going to be prepared to accept a tariff-based model, which I think, debate about what tariff it is, but a tariff-based model. Well, sorry, just to translate that comment, there is a national consultation on a set of neurodiversity tariffs that literally nobody is prepared to say they understand where they came from. They are extremely low and extremely peculiar. There is a set of tariffs that West Yorkshire and South Yorkshire and others have developed together that I think we feel is more coherent. They're not that different, but they're a bit different. So we're just working through whether HMY can lean into those tariffs, because I would be extremely confident that the result of the national tariff consultation is that both NHS and private providers say, if you do that, we're leaving the market. Right. So I cannot believe those tariffs will survive, because nobody is going to lean into. Does that make sense? But in terms of your advocacy for joining North Links, Kat, I think we're nearly there. Yeah.
That is very, very good.
Sorry, just thinking about what you said, Toby, is there anything nationally that's trying to join up the agendas? If we think about like the government's agenda for work, is that work and pensions government actually talking to the NHS to see it?
So I think if you wanted a yes or no answer, I think the answer is no. That there have been attempts to join this up, but the way that often manifests itself nationally, my experience is that everybody would like somebody else to take a lead on this. And that has bedeviled this subject, so to my certain knowledge, for sort of 2.5, 3 years. So it is frustrating, but I guess there's a risk that my tone is downbeat when I think we're making real headway. This paper talks to children and young people where we will eliminate the really long waits, where potentially we'll bring back next time some meaningful trajectories, where we think we've got a way forward, we think we've got a tariff agreed. So without minimising it, because it's a huge deal, we're left with the lack of a backlog plan. That's the thing we've got to work out how we would address, and then we've got to work out somebody who's prepared to pay us for it. But yeah, beyond warm words, Rachel, of which there are a lot in this space. Clearly, it was a national review. We're working inside the national review, but the national review is no more than warm words in terms of how it translates.
You would think that was the case when you go to the obvious.
You would, and particularly around educational attainment and employment.
Yeah.
You would.
Thank you for that.
That look.
Yeah.
Well, it was on time. But there are a number of recommendations on the cover sheet to the report. It's a huge issue for us. I'm just grateful that we are not in a place where people are sitting going, well, of course, all this is nonsense. People don't need diagnosis. Because I hear that from some national chairs. And I take that across. And people say that, particularly when it comes from chairs of mental health trusts. Diagnosing them. We are not in that place. Great. Can we agree the recommendations that are on the front of the cover sheet? Thank you.
So could I just check in terms of the last one about risk management? There are specific aspects you told me about.
So you already have, as I recall, we already have BCSM through the risk management group and so on, a series of rated risks around neurodiversity. So I think the specific ask is to establish, given what you've heard about treatment weights, given what you've heard about weights for medication, can we make sure that we've got precise risks that are described? And secondly, given what we've been saying here and in other papers about our forward look, are we still confident that those risk ratings are as they should be, particularly in the children and young people's space?
Thank you, Tim.
Does that help? Thanks.
Okay. We have Simon's first report to the board. Next.
Thank you, Chair. So this paper builds on papers that the board will have seen before in terms of the financial plan for 26-27, and acknowledges that in mid-December we submitted a break-even financial plan for 26-27. I will go through not all the detail in the paper, but some of the key highlights, actions, acknowledging that on the 12th of February we need to submit a financial plan for 3 years. So it's the 26-27 update and then the following 2 years. So in terms of the paper, it tries to take you on almost a journey from this year's financial plan to the underlying deficit to the 26-27 financial plan and then the subsequent 2 years. So in terms of the underlying, which the detail is in section 2, what that says is by the end of this financial year, we will have an underlying deficit of 6.3 million. I think the board will be aware, but just to remind colleagues, that is a significant improvement from 2023 when it was at 16 million. And based on the assumptions in the paper, we would have a break-even underlying position by the end of the next financial year. So I think it's just worth sort of pausing and realising that based on the assumptions, which I will go through, we will have a break-even plan in 26-27, and I think really importantly, an underlying break-even plan, which I'm pretty safe in saying will be the minority in the NHS. So the journey, the direction that we're going on is really positive. In terms of 26-27, again, just to remind colleagues, section 3.2 just highlights the national assumptions that we have applied. So that's the pay award, non-pay inflation. An important point in there, you will see the national pay award is based on 2.1%. And the current view is the pay award will actually come out at 2.5. The national view is funding will follow for whatever the final pay award is. We all acknowledge that there will be specific challenges for us around the pay award level of funding. I think importantly, just for the board to know, is table 2. So by applying the national assumptions, what would drive out of that is an efficiency requirement of 5.1 million. I think it's just really important we acknowledge that as we go into the future years. So the 5.1 is what we would have to do almost just to stand still. But I've just talked about we have an underlying deficit, so we need to do more in 26, 27. So that's why, if you consider the cost pressures that which are described in the paper, with an underlying deficit, our CIP target is 10 million. And that is to eradicate the underlying deficit, support the cost pressures, and really put us in a really good strategic way forward. I'm not going to go through all the sort of section 6, which details the process, the timeline around the cost pressures. That I think has been very well, a very clear process. Gone to see a clinical leadership executive, all the care groups and the corporate directors have been fully engaged. So if there are any questions around section 6, more than happy to take that. The real focus, I think, at the last board was around the contractual discussions, which for South Yorkshire, we group those into 3 buckets, which are in 7.2. Before I get into South Yorkshire, just building on the back end of Toby's paper around Humber and North Yorks, we wrote to them to put our view forward of what we felt was a reasonable contract, and that was because it was pretty silent from that side, and including the service that Toby has talked through, and also the crisis assessment team. They've come back to us to agree, bar those 2 agreement with everything we put forward, and then subsequently there are the ongoing discussions to firm up the those additional 2 schemes, which I am, as Toby talked through, optimistically confident that we will get those over the line. In terms of South Yorkshire ICB, there were 3 buckets. So one was around the HDU, and we now have agreed with them there will be a form of words around the cost per case, which again I think is positive, and then it's up to us to make sure we are maximising the capacity ultimately to support patients. The second bucket was around the contract variations. The teams have done a huge amount of work over the last couple of weeks, and as I sit here now, there's a couple that are outstanding. One is around the IT contract. I am confident that we will resolve that in our favour. The documentation is very clear. Bar that, there's a residual 1 or 2 contract variations that are being taken forward as we sit here now. Had a short meeting with ICB colleagues yesterday, which is almost the first one, and have made it clear that by Monday, the issues that are on the table, those are the issues. Nothing more can be added or taken away. But summarising, the contract variations have moved in our favour, which I would have expected it to happen because the documentation we had and the governance was very robust, and I think the ICB have caught up with us. So the residual aspects in terms of the 26-27 plan is the mental health investment standard growth income of in the paper 3.63 million, which I will come back to that. I'm not going to go through section 8, which is the budget setting process and sign up, but that's really strong governance to have all of these signed off by the middle of February. Finally, Chair, before I take any questions, section 9 then just builds on the 26-27 plan for the subsequent 2 years. And just a couple of points to pull out of that. The first one is around we will apply the national assumptions again. And what I think comes out of this very clearly to me and hopefully to others is because our underlying deficit, as we exit 26 is break even, the requirement around the CIP and potential income growth is 7.6 million, which is a 56% value of what we have to do in 26-27. So I'm not going to sit and say any of that is easy, but it becomes more in our absolute gift to do these, still stretching, still ambitious, but the CIP level is at a lot lower level than for 26-27. So that's just another, I think, a very, for me, clear example of why delivering the CIP recurrently helps our underlying position. So those are the points I just wanted to pull out from the chair paper with the recommendations provided at the end.
Thank you, Sam. I think you're absolutely right. I mean, getting it right this year is going to be crucial for the next 2 years, isn't it? And just before we take questions, I mean, just to acknowledge the huge amount of work Toby and Simon and the team that is going on with ICBs right now. It is a significant pressure on the senior teams to get this right, and it's not easy. It really isn't. We are in. It's tough, but we're in a better position than many. Any questions to Simon on the report? You've seen a lot of this, I know, but Pauline, please do.
Yeah, excellent report, Simon. Good to see you've got a plan on the long term emerging. You just mentioned the MIS number, the 3.6 million. So I know it's being held centrally at the moment by the ICB. So what confidence do we have around that being allocated out? That was one question. And in your longer term plan, given we're going to be looking at estates in the future, have we included any potential benefit from that? Or do you expect there might be? And is it just too early to put that in, or is that beyond the long term? Just wondered if any opportunities.
I'll do it in reverse order if that's, and Toby may want to come on the MIS. In terms of the estate plans, for me, there will be contributions to the medium term years. We've not put any values against that now, because that's some of the work that we need to work through. But what I can say is, as an exec team, we had a session a couple of weeks ago looking at some of those themes for future years, because we can't keep doing this almost the cutting off aspects here and there. It is more of the, whether we call it transformation strategic work, but that will be a part of that medium term financial plan. But I couldn't sit and say now that's going to be 27, 28 or 28, 29, but it will be a key part of that to support the 5.3 million CIP.
Well, I'm coming to that now. I was going to ask a question as well, if I may. So just specifically on the MIS then. So recognising I'm a MIS skeptic, but the MIS remains with us. So the South Yorkshire equivalent number for the MIS across all providers would be 7.6 million. At the moment, the ICB has a plan to spend 5 and a bit million of that on the ICB. I'll just leave that there. And we're just working through whether that really is a reasonable approach. Maybe a different way of putting that is, at the moment, commissioners are offering £0 and 0 pence for the next 3 years to deliver the 10 mental health commitments in the 10-year plan. So we will see how long that position can hold. So I have no investment proposal on mental health apps, so yeah, got no investment proposal around emergency A&E, got no investment proposal around anything at all. We are not in ourselves and SHPU in the same position, by which I mean that we have a finance plan that we're intending to submit that contains a MIS gap. I get that the 7.6 is difficult. In my personal view, I don't accept that you should spend 2/3 of it on yourself. And I don't accept that the MIS is a ceiling. The MIS, insofar as it's useful, was always meant to be a floor. So I don't accept that 7.6 million is what you should be doing. I don't think that's a unique to South Yorkshire issue. But I'm not sure I'm bothered about that. We need to solve them. So that's where I'm at. Can I make one point and ask one question? So I think particularly, in the minutes, we need to be self-critical enough to recognise that contained in the 25-26 bridge is at least £1 million of unanticipated costs. Some of those costs are unanticipatable, some are not. So when we reflect on the strength of our processes, which I think we feel is pretty good, we've got to acknowledge that, you know, that there is contained in one of Simon's orange waterfalls, there is that margin for error that we would want to see reduced when we look back on 26, 27, and less explicit in the paper, but again, in candor, there are some income assumptions that were built into the 25, 26 plan that are not entirely recognised by those of us that built the 25, 26 plan. Fortunately, we have resolved those issues going into 26/7 as of yesterday. So that's positive and it's not driving a difficulty. But for all the on-plan stuff we've talked about, 22 or 23 directorates on plan, etc., we've got to acknowledge that margin for error, and we've got to see if we can drive it out in 26, 27, and I'm sure we can. My comment was going to be, I'd just draw the board's attention to paragraph 6.9 and 6.10, because normally we conclude the CLE investment fund discussion, known in here as cost pressures, for reasons people understand, before we come to the board. This time we're going to have to do it the other way round. I can explain to people if people need why we're going to do that. So the paper asks for guardrails. 6.9 to 6.10 describes how we're anticipating spending that money. If people want us to consider anything else at CLE, we will bear that in mind. And perhaps in doing that, I draw attention to the fact that the executive advice, clinical executive's advice is that there are no M-host arising issues in 26, 27. So I know Richard raised that in November's board meeting, so perhaps the minutes can record that we don't need to add an M-host guardrail because that's already been dealt with. Is that okay? Are there any other guardrails or suggestions that people want?
So if anybody has a problem with the 6.9, 6.10, that I think it's missing something, or then can we?
Yeah, I mean, look, we got £6.8 million of bids. We got about 50 bids.
Yeah.
So that isn't the list of bids, just so everybody,
No.
yeah, where we are minded to invest or to recognise cost pressures, if that's how we need to describe it, is there. This board should recognise the older adult admission avoidance as being something the board insists on in March 25.
Particularly keen to make sure that the poverty proofing strategies are supported through that investment programme.
That's helpful, Ken.
Nodding up.
That's helpful.
That is very important to this board that we do that. FT articles. It is who we are. Kathy, Dave, I'm going to have to shove you along soon. Kathy.
Thank you. I mean, I think this is super helpful. I think the analysis is great. You're very clear on the areas still to be solved. You're busy knocking those off. We've got a number of different ways of resolving those that you've also been through. So out of all of that, are you left, you feel overall confident, or any particular concerns of anything that's going to be at risk as we get into the next?
I think in terms of the two areas that sort of is one around the CIP, but I think the process, particularly around the workforce and the schemes within the table, I think are very robust. And you know, I know the board has talked about the workforce areas before, but that is really robust. It's really early. It's a good process. So I think the CIP is a really good programme. And again, contextualise, I think this will be well ahead of many organisations in terms of where we are. I think the outstanding challenge is the income discussions with South Yorkshire ICB. That's the area.
And we may come back to the private board if that's stuff.
Yeah.
We may come back to that in the private board if that's helpful.
Yeah, absolutely. Thank you. Dave, and then we will move.
It's just that tension between 200 odd vacancies. We've got there on the finances because of an underspend on people costs. It's helpful going through a period of change that you have vacancies to redeploy people, so that's good. And then we've got a commitment to say, broadly, no more than 100 vacancies was the mantra that we had before.
Yeah.
So at some point, and you do reference that in other papers, so we're pushing for that again with vigour again post-April. And I guess it's just that recognition of it's quite a delicate juggling act to do that as to when we really start to push for 100 vacancies.
Well, I think we'll start to push for 100 vacancies at the end of May, is the answer to your question. I think we are asking our friends in 360 to look at why some of the finance HR reconciliation work went a bit wobbly in the middle of 25-26. I think we know. And what's interesting is it went a bit wobbly in two bits of the business and wasn't wobbly anywhere else. So we just want to understand that, because I think I can say we're going at it from the end of May, and we will, Dave. But one of the things that's thrown us off this year is we were going at it all year, but it went wobbly. Am I making sense? So it's actually, the devil of this is in the absolute local detail. You know, the absolute local detail. And the test of the Valentine's Day sign off a budget isn't can everybody get inside their numbers, because I'm incredibly confident colleagues will. It's whether what sits beneath that is actually micro accurate, because where colleagues have struggled this year is when the headline number kind of works, but the actual budget they're looking at says something different. Does that help? But in answer to delicate balance, we've got to be fully back on this in May, and moving towards being fully staffed.
Okay. Thank you. We are asked to note obviously the cost improvement target for this year, which we well know, and the 5.3 million for the 2 years after. Not easy, is it, Simon? When you've got a 3-year plan. We are up to date on the latest income position regarding South Yorkshire and HNY, and recognising the 25-26 exit underlying position. So can we do that? And it is a remarkably good position compared to many. Chairs talk to each other about this stuff.
Chairs discourage that.
Two other actions in the next.
Oh, sorry. Like 4 week wait, so I don't quite believe
you.
I'll
learn. That's shocking, mate.
Schoolboy era.
So we need to delegate authority for the final submission.
Oh yeah.
To Toby and Polly.
Paul and I enjoy us on the evening chats, don't we,
Yeah.
Pauline? Yep, that's fine.
And agree the submission of a break-even income and expenditure plan for the following 3 years. Are we agreed to do
So
that?
just be really clear about the fifth one.
Yeah, sure.
We will not have a signed contract with anybody on the 12th of February.
No.
So we will be submitting a break-even plan based on the best judgment of those of us involved about getting that. I don't want you to be under the impression we're going to sign a contract on the 11th and then submit the plan. I have nobody to negotiate with who's capable of signing a contract.
No.
So yeah, it'll be based on judgment.
It will. Yeah. And we will continue the work. So can we agree those? Thank you. The patient story was due at 1:10. I'm going to try and get through some more before we do that. We may well slip agenda item 22 till just after lunch. I may bring lunch back by 10 minutes. We only get 10 minutes. So our next agenda item is the carers plan. It is questions only. We viewed this matter in July. I promised to. So just questions only to Steve. Please, if we can, keep this matter to about 10 minutes, if at all possible, unless it we can. Important subject. It's the forgotten issue that affects whether it's patients, their families, or indeed our own staff. Hugely important. So it's a great tape, and thank you, Steve. Have we any questions to Steve? If we haven't, we can simply approve it. I mean, we've discussed this before. It's about getting it working, isn't it, Steve? Really, it's about doing it.
Yeah.
Good.
Yes, Rich.
Yeah, so really good to see the progress. I think perhaps it's just my understanding in terms of the staff element and the carers support that we have. the staff? And you mentioned federation and things like that. But do we have, are we like members of employers for carers and other, is that part of the plan? Just that they come with some great resources that would mean almost carers within the trust could self-service, which often is something that carers need to do.
Yeah, Richard.
You talked, I think, facetiously about bankrupting the local authorities. In terms of risk register, a recognition that if we do actually create a demand that is exceeded, where that risk be recorded.
Yeah.
Thank you, Richard. Right, Steve, over to you and then we'll move on.
Yeah, great, thank you. So if I take it in reverse order, because Natasha Mead and Jane Ryder came to the staff carers network yesterday, where I was very explicit and not facetious and told them that it was our aim to purposely bankrupt them, and they welcomed that challenge.
Yeah.
So what they spoke to and acknowledged was actually that since coming into post in the wellbeing service, particularly in Doncaster, that they inherited a significant backlog of people who were referred into a caring service and hadn't been seen or triaged. So now that they've kind of got through those individuals, we're now working up joint protocols, because actually there is still whilst everybody thinks, I'm not saying everybody in here, an expectation, of course, that local authority will undertake the assessment and then make a determination around eligibility. Actually, there's a responsibility for our NHS services under CHC, so continuing healthcare, actually to consider carers as part of that assessment, and as is with dialogue as well. Dr. Ford, so absolutely, we will continue with ensuring that this is a real joint approach. And I suppose what is really encouraging is some of our primary care networks. So Northfield, for example, have somebody who in the reception area directs people for a carers assessment, or provides, because not everybody's eligible for an assessment, but everybody isn't eligible for a support plan. Yeah. So sometimes it's that local knowledge and signposting people really early. That makes sense. And then Rachel, yours certainly around staff. So what we've seen is a multi-pronged approach with Carleen as well. So looking at when we started this journey in April 24, we had less than 50 people registered on ESR as carers. We've now seen that grow to today's number, which is in excess of 150. And I'd expect that to grow probably, if we think about the national projection of percentage of carers based on populations, around 250. So we've still got a way to go to perhaps identify another 100. But also within that, what we're doing is looking at gender mix, protected characteristics. Yeah. So we know actually that the large proportion of those people are white females, and of course that's reflective of our demographic as a workforce. But actually, when you sit on the anniversary of the Carers Network, which was yesterday, there is only one man on that, and I'm the sponsoring executive. So we've got a responsibility to also reach out and touch other parts of our staff groups as well. What was really interesting, that we had the Doncaster Wellbeing team, and they shared a lot of the services they offer that actually are way before a formal carers assessment. And often it's that dialogue and relationship within the community. And that's where we see the real strength actually is now. Local authority have kind of got their house in order, which they were very open about. So I'm not speaking out to actually what joint working can we continue to do with Chad and other organisations. So we're doing the same as well, replicating that in North Links and Rotherham as well.
Yes, Richard.
Just one quick point. We're talking a lot about the 555. So I've literally had a request this week that someone said, one of my managers, very expensive, said, oh, can I buy some unpaid leave? Because my caring responsibility is building up. I'm confident that the manager's going, no, we won't be doing that. How can we sort of work this differently and things? So I think there's a lot of infrastructure, but there's still that culture of being able to support all other managers to go, how can we work through flexible working or adjusting to be able to, work in a slightly different way? I'm not sure every manager's got that confidence yet.
Yeah, come back, Steve, if you need to.
Yeah, so it's really important as part of the induction training, as part of the first line managers training. Colleen, that is nodding, that is definitely in there. But I think there's something really important about what we've heard over the 12 months of the evolution of the carers network, and that's the wellbeing passport for staff. So at PDRs, at supervision, that the manager is sitting down with a wellbeing passport because it enables that conversation. And Jude and Toby have spoken earlier about some of the shame, but some of the shame of that as well, about admitting that you are a carer or you need additional time off, particularly I think in the context of where we're going through a number of changes within services. People are feeling a little bit fragile and maybe coming forward and saying, I need time off because I'm a carer. So really kind of linking that all together and making sure that, managers are talking to staff throughout this consultation period as well, but also ongoing with the wellbeing passport, because that's been really, really well promoted.
Yeah, it's a big.
Just to comment, I think it's a really helpful paper. I know Steve's waiting for me to say how it compares to Dermot's, but I think it's
I was waiting on the CQC one for that.
And if I will make is, whilst I admire paragraph 6.4's attempt to get investment in a carer support function, that won't be being funded through the bids, as Steve knows. So the resourcing for this will come from existing central teams.
Out here, probably. Thank you. What are we doing? I think we're recognising the work done from April and trust-wide work from April. Thank you, Steve.
Can I just make a shameless plug for
Yeah,
the anniversary event on the 17th of March? It's our first anniversary event between 10 till 12 at St Catherine's House. So really welcome board representation there.
Right, thank you. And can we agree to receive the report?
And discussed with the delivery changes sufficiently understood. Welcome the First Nation delivery change.
Absolutely.
Very well.
Absolutely. What I'm going to do is I'm going to quickly take the report on the commissioned review of well led, and then we'll take the patient story. Then we'll break.
Right.
So Phil.
Thank you. Just literally a few points that I just want to flag. Obviously, we talked about this last time. Since we last discussed it, Pauline and I worked through a procurement process. I'm very pleased to appoint Value Circle, who are already here. Part of one of the first things that they've done. So we've had the appointment process. We've started to respond to a data request in terms of documentation that we needed to see. There's been an opening meeting between the chair and chief executive and representatives from TVC this week. Obviously, observations at the board and committees have now started, literally today, and there is a series of meetings in the next committee meetings over the next couple of months will all be observed as well. There will be a range of interviews held with individuals. So within the next 7 days, you will be we will arrange that for each of you. And we expect that by the time we meet again in March, that the Value Circle will be providing us with their findings, their key issues, and we'll talk about how we're going to respond to that and receive that as important. So it's really just to keep you up to date on where we're up to with that point.
Thank you. And I'll bring in Richard, but obviously thank you to Philip and indeed to Pauline for taking us through that process. You all got the emails around that decision. Just to really to make sure that you do take part. I mean, everybody's going to get those meetings. Please treat them with some, what's the word? Make sure they're in your diary and you don't think, oh, I don't have to. We're not doing that.
We might pick up in the prior session what the review really is.
Yeah, thank you. Richard.
That goes to my point about shamelessly taking pretty much all of February off myself.
Yeah, this is true.
The Appendix 1 talks about the interview stakeholders and the board committee observations ending in February with no QC till mid-March.
Right.
The same. So just
it's recorded across the next.
It's recorded.
Yes, true. It's more that you can't
Richard,
comment until it's happened.
everybody's going to the southern hemisphere and back. I've had Joe Cox go, Kathy's been and come back, now you're going. Is there's something we're not picking up here about
It's not so much
moving
it's
the whole thing
recorded,
to
it's
Australia?
the observation finishes at the end of February. The next meeting isn't until March.
Will make sense of that.
Makes sense. That's very helpful.
If you're in Australia, can you just have a look for any decent rugby league players?
Oh, I thought you meant.
Everybody keeps
You went one way, I went the other. Come back with a fit man, eh?
Sorry, the point is we may have to flex the timetable. We'll work with that. And I'm hoping what Phil's doing is setting up the chairs for our visitors.
Yeah.
I think he is.
Yes, so we will thank you for that and just say that encouraged to participate. No good if you don't participate. And we'll take the patient story with you. Take the 20 minutes.
And no more.
20 minutes and no more.
Yes. Yeah. So, no, do. What you think is like sort of get on space.
I think it's
No, I just need to. What I need to do is I've got to. The backs and bottom. Yeah, I need to bring it.
I think Carly's just done the.
Yes.
Oh, yeah.
Gonna try that. Yeah, thank you.
Oh, you're right.
Right, welcome to the board. Lovely to have you here. Over to the patient's story. We're running over. Could I just ask you to make sure you stick to about 15, 20 minutes?
Yeah, just give us an hour and we'll cut it off.
Thank you. I was supposed to cut you off. Thank you, Catherine. Over to you. Or Steve, just picking up.
No, straight over to the team.
Straight over to the team.
Straight over to us. So we'll do introduction. So I'm Catherine Bev. I'm matron of community and long-term conditions.
Cheryl Scott. I am the Love Sleepers mental health care support worker employed by PFG to work with the starting point team. I'm Vicky Donaldson. I'm clinical lead tissue viability and lymphedema in Doncaster and Ashton.
I'm Sam Butcher. I'm the nurse director for the physical health and neurodiversity care group, and I'm purely the chauffeur today.
Happy 50th, Dad. Happy 50th.
Yeah. So I know you've had a summary, so we're here to talk to you about Matty today. Matthew Colbert likes to go by the name Matty. That's who he's named to all his friends and us as well. So Matty could be here today, but we talk about story, but we're going to go a journey. Matty's on a journey and it's a life journey. It's not a story. We haven't got an ending. We haven't got him sat here today to be able to tell you because he's on a journey and we're with him on that journey. So it's as raw and real as it is. So that's what we'll do, or we hope to do for you today. It's not rehearsed. This is just us telling you the story. So I'll over to Cheryl, because you're the absolute expert in Matthew's journey.
I have known Matthew, oh gosh, I can't even remember how many years. More recently, I was his drugs worker, and in this new role, I'm his mental health care support worker. Matthew he's different to most people, but because of his legs and his wounds, I think it's very, very, very difficult to get inside a building at a set time. Sometimes he'll come. We got him going quite nicely about over a year ago. His wound became less than half the size. Then getting him to come to the appointments, then he drops off. Because it was to start with, so we're on that on and off treatment journey at the moment again.
So obviously that's where tissue viability comes in. I've been in tissue viability for the last 30 years, so I've got a really good history of our service, and it's got to be about 20 years ago we were doing quite a lot of drop-in sessions for homeless and complex lives, and initially we did used to do those in soup kitchens, church halls, and that's where I first met Matty. And yes, over the years he's had recurrent bag ulcers, he's engaged with treatment, he's not engaged with treatment. There's been different different posts put in to try and get this client group to try and conform to normal services, which obviously isn't always the right way to go. So we tend to pick up where things don't work so well. And I've been to do a leg ulcer awareness day for RDaSH, and I got a telephone call from Catherine to ask if a member of my team would be willing to go out and see Matty on the streets. And I said, well, I would rather go out and do that. So we arranged, myself and Catherine, to go out the following day, which we met up with Cheryl and went around with our little buckets with everything in, trying to look very inconspicuous what she stood on Doncaster Town. And we got to Matty, who was asleep in his sleeping bag, and he looked and went, I'm not having a leg done. And I said, right, okay, can I just sit on your bed and have a little chat with you? So he moved over a little bit, let me sit down, and broke the ice with him from him trying to remember me from the previous clinics, and luckily he did. So we then did agree for us to be able to change the dressing that day. I had wonderful support with Catherine, who was my dirty nurse, but we literally had planned before we went that she would strip the leg down, I would have everything ready, we'd be straight back on with the dressing. But whilst we were doing that, I was trying to engage Matty to find out what are the barriers, how can we help? And he did say, he said, well, I'd come to you girls because I know you all. And I said, well, we are doing a session on Wednesday afternoon. And he says, oh, well, we didn't know it was you. Right, okay. We've helped you now today. Will you be able to help us? So he has spread the word with that. And on a more positive note, because Matty does engage and disengage with different services. He has been to his GP practice and attended a couple of appointments there. He has been to one at FCMS. He has also been to 2 appointments at our Cantley Health Centre as well as coming to the drop-ins on a Wednesday afternoon. So again, I think it's just trying to adapt what's going to work for him at that time.
And I think it's important that we're leading up to that. So we're talking about leg ulcers, and I know not everybody will understand what a leg ulcer is. It's a really expensive wound, and that wound had not been dressed since March. This visit happened in November. That's really tough going, really tough going. I've never heard of the dressing being on that long. And then I looked to Mickey as an absolute expert and says, neither have I. So it's actually, what are we going to do at that time? And it's just, we are who we are, he is who he is, and this is what's within our gift, and we'll go out and do it and try and engage in that way. And it worked. And I think the one thing keeping alive were the heat in summer of what did you call them? Free range maggots. So we do use maggot therapy on wounds anyway, and we would use that. But that's probably what's kept Matty alive all summer, the free range maggots, and keeping him. And he absolutely needed it because maggots die when it gets cold. That heat dies, he absolutely needs it. And that's why Cheryl, in your role, going out, being near him, trying to engage him, trying to escort into his appointments, noticed the difference in the smell, noticed the difference that he'd been sitting outside the chicken shop for longer, wouldn't usually be there for such a long time.
His behaviour had started to decline, and that's why my concern, he wasn't moving, he was staying in the same place, he wasn't getting, I mean, I don't know what time we went. It was still bedded down at that time, and I thought we're on our way out here.
So you were real concerned, didn't you?
Yeah, because I work very, very closely with this person every single day. But for me to feel like that, hence why I contacted. Steve.
I think just to, I suppose, just to share the conversation that I've replied to in the car on the way here, what comes out most is this isn't about a specific service provision. This is about people knowing who to go to and just being flexible in being able to just go out. So I think, as Nikki's described, we've had lots of different posts that we've had somebody working with our Aspire team before as a fixed term, which worked really well while it worked, but actually still it is about that, just working differently, working more creatively. It's about the relationships that's really important, and that's what's made the difference here. And will next week or next month.
I'll keep going to Jane. That's so Jane. Matty wouldn't let me and Mickey sit on his bed. And when I say bed, it's cardboard and his sleeping bag. He wouldn't let us sit down next to him. And Cheryl weren't there saying, "These are my mates, they're all right. Come on."
You trust them.
We trust. So we have that. So then it's then what happens after that as well. It's then we say, right, I'm there. I'm gonna get pet seating. They're my friends. Pet seating are my friends. Are you gonna let them take blood? So then you let that happen at the next appointment as well. So just that important of us all seeing that without everybody working together and the patient seeing that we're all friends, because that's ultimately what them words were said on that day, nothing more, not about contracts, not about anything else, about us being friends. That's what allowed him to get that care at the time, and that's what will allow him to do it again, because he will. He's just got different priorities at this time, and we don't have to understand them priorities. We just respect that his priorities are different to ours, and he will need us, and we will be there again.
I'm sure I've got. Can I just say that is just a minute story? I know what it is.
I can say we have got some photographs if anybody's.
My husband was hospitalised with acute lymphedema cellulitis last year, and leg ulcers with them. And when I think of the service that the service that we had at home from a CHCP, which was tissue nurses, and what at length of time that dressing been on, we have people coming in every day, obviously, and all of that. So I'm translating what happened at my house to what was happening on the street, and but thank you, because it just demonstrates that do something about an individual who many people have thought of.
Yeah, all barred from.
Absolutely. So, well, I'll bring some questions in and we won't take too long, much of the time, but Toby, Jude, Dermot? No?
I was just looking quizzical.
Toby, Jude, Richard, Steve. Toby.
Yeah, thanks for your time. I have a feeling I've met that today. I may be mistaken.
You have.
Yeah, I think we are actually, as I recall. And from my memories, one of the biggest issues from that is he thinks people will be repulsed by smell and so on. And so you could show us pictures, but in some ways that's what I remember. I guess I'd be really interested either today or subsequently in how we can think about understanding the barriers that quite practical barriers we create to people accessing services, whether that is we don't like the smell, or whether that is you can't bring your dog here, or whether that is you can't come with cans. I think there's a real job of work for us to do to think about our barriers and to work that through. But I mean, I wonder if you had, because you've got so much experience over the years, whether you've got any reflections on that.
I think we had that conversation over here, didn't we? That where they currently go for some of the dressings, they can't go out into the car park and not smell.
Yeah.
Or
okay.
Have whatever they want to take.
Yeah.
And when we used to do the silk kitchens, they would go out and do that. So we may get 10 people turn up all at the same time. They don't want to wait.
Yeah.
That's causing them anxiety.
Yeah.
To reduce their anxiety, they go outside and have snow or whatever. So actually to put another barrier up, we're causing more anxiety. Yeah. So it's actually trying to find out more creative ways of, do we take 3 or 4 clinicians to quickly get them all seen, sorted? Sure. Then they're happy, they're more calm, they're more receptive. But you've been saying that they're looking at opening a new building on Duke Street. Yeah. So again, is that somewhere we need to be looking at going? And providing ad hoc times. Yeah. Because that's the thing. They don't always want to be up before 5 o'clock in the afternoon. So actually us going later on an evening, would that be better? So there are those flexibilities, we've just got to look at those different ways.
I suppose that's us going to someone else's house rather
Yeah,
than
yeah.
insisting they come to ours. That feels really powerful.
Yeah.
No, thank you too. Jude.
Thank you ever so much, and thank you for coming here. Even though I think it's really important because we could just say this story, and that's wrong because we wouldn't hear the really important people that we serve that are usually the most disempowered and the most likely to die much earlier than other people. I guess there is multiple reasons, like Toby said, that we can look at, and we discussed and didn't show at Christmas when we had some people that didn't want to come in and have Christmas dinner with us. And they didn't want to come in because they don't always sit with the rules of us.
Yeah.
So they didn't want to come in without having a bit of drugs or a bit of drink. They didn't want to come in because other people might be around them. They didn't want to come in because there's an hospital sign outside and it's hard, isn't it? But a good thing about what happened at Christmas is that you let them know where we were going to be and how we will pick them up and where they could come. And I guess building on what Toby asked, there might be something in that was about being at a place at a time, because like you said, once he knew it was you, he was happy that you weren't going to judge him or do anything else. All you're there to do is try and help him.
Simple. The reason why he remembered me, I always used to wear a cat t-shirt, so he remembered me as the cat lady. And again, that took that barrier down straight away.
And it's really important that we do that, and that we go the extra mile to move people out, because some people will live that life forever.
Yeah.
Some people we need to keep alive to the point where they would like to do something different. And we've got an obligation to both sets of those people. So I just think, I suppose I wanted to bring that in because I think some of the things we were talking about at Christmas Day really could be as well applicable to what we're talking about. But also thank you, because it's not a nice job, is it? Because sometimes we go out and we see this, and the people that we find and what we find under those wounds. I remember a few years ago when I did this, it was an amputation. It was gangrene. It wasn't at all salvageable and so it is quite traumatic for you guys to see that as well.
And where are I now? Richard. Oh.
Thanks very much. I'm a retired GP, so 70 and there, and I was in North Links and saw a very similar kind of guy at the Ironstone. Similar to get to them. So commend you. Just thinking about the obstacles. We talked earlier on the board about policies and did you have to actually breach a few policies to engage in the first place? I can imagine someone saying it wasn't safe to go onto the streets and
Steve wants to come in. I
didn't even look at one to check if I were or not. I just arrived in at my time. That's honest. I was the matron. I said to Nikki, I'm not going to ask you to do anything that I want to do myself. If you're happy, I'm happy. Let's go together.
And we just went, that was our saying, we went
It's easier to
together
ask
and we
for
wouldn't
forgiveness.
even share it.
Yeah, and I just did the right thing at that. Might have done, still not checked.
sort of throwing it out, thinking out the ground. That's exactly what
I've got my safety network with Cheryl at start first, and I went on as well.
I think the only one I had in my mind was the clinical waste, but we've always had our red buckets, and I've kept them over the last 20 years. So we just got them from out the back of the clinic and off with them.
Go and take Rachel, Steve, and then bring you in last. It'll be nice week.
Okay.
Oh, okay. Just wanted to just a few reflections. That's all, Cheryl. I think we met when I was in a different capacity a long time ago.
Yeah.
When you started out, so it's absolutely brilliant to see the difference you make. So I think those conversations were about, will agencies work with me? Will they realise that I'm the conduit to the people that we're here to serve? So it's brilliant to hear how it's, in one example, it's really worked. And just a reflection on in your comment in terms of why Matt's not here and how you accept that. And I just think other organisations need to think of it in that way. Obviously, I've got lots of experience in Doncaster with the Complex Lives cohort, and many of the issues are around not just organisations, but the whole community in terms of, as you've said, he's barred from here, he's barred from there. And it's about how we, as an organisation, get people to be a lot kinder in terms of seeing this person for who he is. But my question really was around, it's brilliant that this has happened and the way you've gone in is just fabulous. It's almost like getting to that prevention and how, Toby, we managed to embed this into sort of like the health and wellbeing framework and everything. Because I often think with people like Matty that I've met in the past, if we'd have done things differently at some point and would have responded a little bit differently, he might not have been in the position he's in. I know that doesn't apply to all, but often people have said to me, if somebody just, when my nan died, was there for me to talk to, I wouldn't have probably gone down the route I've gone. So I suppose it's about understanding how we can do that.
We spoke about that again, about not just Matthew, but other people that are part of the services. And on paper, yes. Would you meet him down Dark Alley? Absolutely not. I would go anywhere with that man. It's not the person, but if he's having a bad day, he's going to tell you to go away. and most of them, you've got to remember, nearly every single person that I work with is heavily in addiction, not just one addiction. Some have got fat. If you aren't scored, you're rapping and you've had a bad day. You might not have slept all night. You might be wet. You might be tired. You might be cold. And then somebody's going, yeah, you can't come in. What are you going to do?
Yeah.
Whereas I'd say, shut up, come on, let's get it over and done with. Let's go in. It's going to be fine when you get in, but we don't get to that. The people, the use of people saying no, there's too many. Too many rules, too many regulations.
Thank you. Thanks, Rich. Steve.
At one point of clarity, one point of economic work, and I just want to put some context to it. So the point of clarity is Mickey, clean nurse, Catherine, dirty nurse, IPC term. So wound off, dirty nurse, new, I need cleaner. So just make sure for the non-clinician that's really clear. Then acknowledgement, show you are literally worth your weight in gold. So thank you. Thank you for all the work that you do. And I say that genuinely. And of course, the way that the team responded. But I just wanted to read your email, Cheryl, that you sent 1642 on the 26th of November. Hi, Steve. I really could do with your help with someone that is at risk of death on the street. I would like to pick your brain to see if I can resolve this issue. I can explain, so call me. Then at 17:32, Catherine Bebb replies and says, we'll see Matty tomorrow with Mickey. So a phone call. So when you talked about have they thrown the policy book out the window, absolutely, because what you'd expect or traditional service would say, no, A&E, it's if this person at risk of death. A phone call to Sam. Sam rang Catherine within less than 24 hours. So we talk about promise 14 and 4-week waits. You think this person may have been sent to A&E, may have been sent to his GP. How long would that have taken? And it's just a credit to the team and the work that's been undertaken.
So we're going to feed you.
Yes.
I think that's the plan.
Go on, Joe. It really does. It really, really does. It's one of the best stories I've read in my life. Credit to you, and just credit to the fact that you acted rather than waiting for some.
Can I just say, Steve, thank you. The response was phenomenal because I am out on the streets with those of you who call me every day, and I never ever get an immediate response. It's always this person, oh, you need to do it, you need to do it. There's always, I have to go through, you won't believe the things I have to go to get from A to B. So the response there, I nearly fainted. No, I really did. I'm not used to getting somebody to email me back so promptly. And once Steve said that, and I spoke to
It's all like, well, that bring it.
Couldn't believe it. Could not believe it. So
the right thing.
So that
It is the right thing to do, and we'll put the right thing to do in front. That's what we do. We are going to feed you. I'm going to break for lunch. I'm going to ask people to come back for 2 o'clock, please. And we'll continue. But yeah, please have some. Item 22 is in his name and go to the IQPR, which Richard can cover, can't you, Richard?
Yeah.
So.
Challenge accepted.
Yeah, just take us through the highlights and worries of the IQPR, Richard, please.
Yeah.
If you would.
Okay. I'll just. It won't take extra. Sarah's not here.
Sarah's left.
Right.
Oh yeah, Sarah's gone.
Okay,
Yeah,
that's
Sarah's
look.
got the rest of the home, so
Okay,
Sarah.
no worries. I just wanted to maybe just the IQPR is the golden thread of what goes through a lot of committees. Sarah talked about the increase in section 136 at the Mental Health Act, which is a really helpful point. You'll note in the December IQPR, I did note that there was a 200 hours spike, and you know, we need to keep an eye on that. So I think it's helpful to, and Dermot going forward, I think will help maybe that particular committee to sort of understand some of it, because I think if we go into December, so what we're looking at now, there is 97 hours, so we've already gone down, but of that 24 hours is state, so you all know, oh, I've seen it. So we've had planned closures of the suite in North Links for electrics, for doors, whatever, and we have to do it in a really planned way. So you'll see that in December's data and January and potentially February data. So 24 hours of that. I think then there was 10 hours was clinically appropriate. Very occasionally there is a patient who is probably intoxicated, to put it another way. So you've got 24 hours, but you can then legally extend for a further 12 hours. So they're then clinically available for the assessment. So that's the other bit of it. And then 47 hours was in terms of the section 140, and that was full time. There was 14 hours for cleaning. That is of concern. That's way too long. So of that, I suppose that would be one of the areas I would say we could continue to look improve on. So in terms of the IQPR, I think in terms of from a performance perspective, I think we're still strong. So within that, I think Toby's already referenced, you know, we've continually met our 18 weeks targets. We're meeting nearly all of our access targets in terms of children's and contact with adults. Obviously, we continue to narrate that we're not meeting our talking therapies target, access target, but we've also seen an improvement on our reliable improvement. I've talked before about where that will go up and a little bit down, a little bit up and down, but some of this will get picked up as we go into the planning round, because nationally I won't get into this now, but nationally there's been a sort of a drive to try and drive up some of these, some of which we're performing quite well. I think in terms of the quality space, then it's clear, I think there's been improvements, particularly around falls. I know Steve was keen that we acknowledge that. It's the first time that we've met the new metric of the 12 hours falls. We're still not meeting mass though, and also there was, again, just in terms, I think we were 88% in terms of the safer staffing. So if you want to pick up any questions to Steve on that. As you can tell, I'm furiously, you've thrown me that I was in next, and I'm just trying to find the front sheet. I found it now. So I was working from memory there. I think in terms, we've talked about finances, so I'm not going to go through that. I suppose obviously just noting the risk around HDU for this year. I suppose the areas, again, Toby's talked to this, but I suppose our vulnerabilities in terms of our people's metric. This month delivery reviews, we've gone through quite in finite detail around the PDRs. They're all extremely high, over 90 plus, but we're looking for as close to 100 as we can. But our sickness remains high. I think this is at 6.59, and then obviously it's currently set at 5.9. Over the next period of time, we need to be moving towards 4.1 over the next couple of years. That's not as easy as it sounds, I suspect, and Colin, you might want to comment on that. And I suppose it's a notable increase in short-term sickness and stress and anxiety, which was about 42% of those absences. So I'll take questions on anything else.
Thank you. Just to note that the regional meeting that Toby and I were at, they were particularly interested in our assurance around the ability to deliver the reductions in sickness levels that Richard just spoke to. Is your board assurance?
Yeah, but I think I mean that's a sort of computerized answer, isn't it? So I think I don't think we need to do anything different to what we're going to do. If I'm honest, I think we've got time.
Very strong.
We got time set aside to consider how we're going to approach that, and so we'll bring that back to the board in May when we've had a chance to work that.
Colin, do you want to comment on that? You will.
Just to expand on what Toby said, we've been very realistic with our projections though. There's an expectation to deliver 4.1, a desire for us to deliver 4.1 for the end of the 3-year planning cycle. That's when we've indicated we'll be around the 4.1. We have to recognise there is a north-south divide with the sickness absence though. Southern trusts are trending 1 percentage point lower. From a planning guidance perspective, there's nothing in there to take that into account. But we're doing a lot of work with our managers, and what I find really promising is the commitment the managers gave and understanding their data and looking to work alongside colleagues rather than a textbook answer. I'll meet with you at such and such, meet with you at such and such. They were really understanding their long-term sickness data, recognising that accounts at the present time for 2/3 of our sickness absence. And Toby's touched on the wider work that we're looking to do, the different approaches. All of that will come together, but it will be a journey.
You've mentioned how we need the issue that we are going through this massive change programme, which sickness will be affected by that, and we are separating out this question of people who are ill and well off sick for other reasons.
I don't think we should ever talk about 4.1 outside. It's meaningless. It's a completely meaningless metric. No one knows what it means. Everybody thinks they know what it means. We need the people off sick who need to be off sick, and we need the people who need to be at work.
Yeah.
Can I ask a question? Can I come back to this 88%? Because every time we have safer staff in the IQPR, I'm really troubled by this number. I need to understand that every time we had a shift, we safely covered it.
Yes, we did.
So why have I got an IQPR that talks about 88%?
It's the way that the roster discipline was applied to them. So when you talk about the head room, there were, for example, on areas, too many people placed on annual leave, combined with maternity leave, sick leave, and as such, it shows that safer staffing numbers weren't completed, but there was always enough staff on shift. So, for example, if there were 2 staff nurses that were due on with 6 healthcare support workers, if only 4 healthcare support workers turned up, but we had an additional 2 staff nurses, it would show us that we were in a deteriorating position.
Okay, so maybe what I'm trying to say is that from April, I want us to found a resolution to the dynamic you've just described, such that what we are reporting here numerically is the lived experience of the wards. Because your explanation is really plausible, isn't it? And I buy it. But I'm looking at data that says something different. Does that make any sense? So we're going to have to do some conversations outside the room, I suppose, about how we get to this.
But to that point, it will be really helpful. And with the Quality Committee and Quality Safety, do look at where because we go red and green.
Yeah, so, no, I remember that, yes.
Well, but by virtue of that, there are instances where perhaps there is 1 RMN on shift, as an example, when there should be 2. But then there may be cross cover throughout the unit.
So maybe what I'm trying to ask is that what we need to be interested in is how many shifts are not red, are not green, not some other calculated number. So that means we need to change the IQPR from the 1st of April. Let's change the IQPR from the 1st of April, because what we're interested in is how many shifts were not green, not something else.
Yeah, that's get that. We'll leave that one to into. Any further questions to the IQPR? In that case, you will agree to receive it. We are particularly asked to note the comments regarding health inequalities. If we do that, please, and then receive the IQPR, and thank you to Richard. I thought it wasn't too never.
I'm such a shy retiring.
Yeah. We will go back to agenda item 22, which is Promise 5 and is headed up making it real. Obviously, Promise 5 is our key contributor to that nurturing the power in our communities statement and the benefits that we get from. Rachel's already mentioned the governors on a committee and what the involvement and contribution we are. So Toby can introduce the paper, but there's the community involvement framework, Toby, that you particularly wanted to draw out.
Yeah, sure. So first of all, apologies for being late for that. We're trying to make sure some letters we send to staff are right. So in terms of this paper, I'm going to assume people have had the chance to read it. And I'm going to adopt a fairly self-critical or institutionally critical approach to proceeding the paper. There's plenty of congratulation possible in this space and lots of good work, but there is obviously a risk of tipping over into self-congratulation. So I think we need to, as it says, keep it real. And there are areas where we're not quite there yet, and those are listed under 2.1. I think a number of those things will come good between now and the beginning of July. I think we should be particularly fussed about the lack of progress on the membership offer, but over the course of the next 3 or 4 months, we need to see that come right. But the heart of the paper is 2 other things, Kat. So one is, I think, some interesting reflective work that Jude's led, which is preceding the table in the paper, about when people are in our spaces, and I guess it applies to when we're in other people's spaces, how accessible and meaningful is the way in which we work. I think that's something for us to reflect on in terms of this board, but also the other spaces that we lead. And then the second is we agreed something called the community involvement framework, the essence of which is 20% having people visit us and 80% us being in those spaces. And I can talk for as long as the board needs on what that really means in practice. But I guess if we think forward a year, I'm interested in what we would want to be seeing that would persuade us we're making real progress with that. Does that make sense? That's what I'm describing with the CIF. Just in order to confuse absolutely everybody, people will have noticed in the paper that we're about to go live with the long plan shadow CLE, and about to means March. I think the term shadow CLE doesn't really work as a labelling. It makes a lot of sense to us, but it slightly others the people that are going to be there. So pending the first meeting, where I think it'd be important to give the people who are leading that meeting the opportunity to find their own identity, we will be adopting the term CLE, i.e. Community Leadership Executive, or Communities Leadership Executive. For that, I've referenced that as COLE in the paper, so I don't have 2 things called CLE and I confuse absolutely everybody. So those are some of the things that I guess I'm trying to describe. I think, as I say, Kath, 2 good board conversations would therefore be, how accessible are we and what are our reflections on how we make things more accessible, not so much in terms of invitation and more in terms of ways of working. And then, as I say, this conversation about how we make sense of, are we really getting somewhere, particularly in terms of the reaching out bit of the CIF. So that's why the paper's here. I'm going to say one more thing, and not just because Dave's put his hand up and I want to put him off. You drew to my attention, Kath, the power of the introduction and the cover sheet about power. I'm very conscious that this board has lots of new people within it over the last year and a half. A huge amount of time was spent as a board in 2023 talking about power and talking about how we would need to be different in order to share power. And it may be slightly beyond the post-lunch session to try and do that here, but I do think probably Phil, we need over the next 3 or 4 months to create space where we can re-have that conversation. Because some of us are old enough to have forgotten, and other people weren't in the room when we had those conversations. So it'd be worth working that through.
That's fine.
I'm quite for Dave.
That's exactly my point.
I wasn't going to. I've ruined it. I'm so
I
sorry.
do think it's important we do that. I think the introduction is very powerful. Some people find that idea of power sharing, giving power up into a bigger community, either scary or some sort of dereliction of duty. Oh, just play them there. It is an unusual place for an NHS board to be. We know that we are different. We make no apologies for that. But people looking from outside, not the communities themselves, other NHS colleagues, bodies, you know, might think, well, it's their flipping job and that's what they get paid to do. Don't start asking other people to make decisions about it. This is absolutely right, 100% behind this strategy and what we do with it. But we do need to know why. We need to be able to articulate the why. We can do that in different sessions. Really important on board and that we can articulate it well, that we're on board with it. If you don't articulate things well that you don't believe in, you don't dead.
No, Toby's answers it was about power, you know, from issues that were raised yesterday in the People Council, you know, just kind of brought it back to the front of mind. So it would be good, completely agree, that devote some time collectively to really understand it.
And somebody said to me in that meeting yesterday, the staff are a community too. And I think that is an interesting discuss some of those A-level questions, isn't it? Staff are a community to discuss. I think it's a separate place, but you know, it's about being able to articulate why on that. Shabby.
Yeah, just one quick point, Chair. In terms of power, it's a very abstract word in terms of the context you're going across. Is it consultation? Is it participation? Is it involvement? You're talking to your staff within, in terms of giving you feedback, and you're talking to out there, you know. So I suppose what I'm saying is, what is the absolute to do as a trust in terms of, you know, the prescribed stuff that we need to do? So how well are we doing that? And then once we understand how well we're doing on that, then we can start looking at actually how further can we go. Am I making sense?
You're making sense, yes. But I'm going to completely reject your frame.
Yeah.
Okay? It's a really rational frame and it's really helpful. And I suppose what it brings to my mind is the conversations I've referenced that we had as a board 2 years ago, where we had to work this stuff through together.
Yeah.
So I think no, it's not my point, Shabir. My point is we all need to work it through together. Yeah. So I can give you my answer to that question, none of which involves word-site involvement and so on, and none of which sets that boundary. But I think what we need to do as a board is to work through together our shared meaning of that, because we're at the phase now where we're wanting to even more break down boundaries between what the organisation is and our communities. That's why we're going to end up with a clinical leadership executive and a communities leadership executive, and one isn't being involved in the other. So I'm not trying to play riddles. I think we've absolutely got to work it through. One of the NHS typical behaviours, it very commonly is to decide that we'll get to all that complicated, messy community stuff when we've sorted out our stuff. And I think we need to not be doing that, if that makes any sense. Equally, you've got to be honest with people about what they can have power over and what they can't have power over. So perhaps we could work that through, and with the benefit of lots of new people in the room, we can come up with our version. And then, of course, if we did that in, let's just say, June, when we have a timeout, by then we would have had 3 meetings of the communities leadership executive. So it may be interesting to set them the same question and see, you know, where we go with that. Does that help? It's meant to be not a rebuttal of your question. I think it's a really good question. Thanks.
Think about participatory democracy. Rachel, Jude, Deb.
Yeah, so I'd take your first point, Toby, in terms of not being self-congratulatory.
Yeah.
I do think we have to be honest that what we're doing is a little bit different in a good way.
Sure.
We need to acknowledge that. Just some reflections, and then probably my questions, because I wasn't here in 2023. You might again say we could discuss that. I like the word executive, that we're calling this an executive.
Yeah.
Often what happens is you have a group that supports the executive, and automatically that changes the power dynamic. Sure. Doesn't it? You're the user group, we're the executive. So I think actually just things like that are really important. Your question in terms of how will we know that we've been successful? I think it's incredibly difficult, because you could do it in a quantitative way and to say we've had all these opportunities, but for me, the only way you can do it is through that lived experience and actually do that qualitative to see how it's almost changed and track that involvement. I think and also we often think, don't we talk about communities, and I think it's referenced in the paper, that everybody who attends that meeting are at exactly the same level, and we know they're not.
Yeah.
We've got people like Glyn, who is an expert, he's very good at advocacy. You'll have other people that have never been in that setting in their lives.
Sure.
And it's about how we support, but not in a patronising way, almost start from where people are. A practical question is, do they get paid? But again, that might already be addressed, so sorry if I've missed it. And I'd really enjoy the time out in terms of seeing how we can collectively shape this and lead the way in terms of that we really do want to nurture the power of communities and not in a tokenistic way, which is what often happens in the NHS.
So for sure, people get paid. That definitely happens. It's also the case that if I was heard to say, let's not talk about that because we discussed it before, that's the opposite of what I meant. My point was, let's come back and have a proper discussion rather than giving you a sort of half cut or cut down version. Forgive me. I think executive is a really important word. And one of the most encouraging conversations I've had over the last year is when we took the draft terms of reference for what was then called the shadow CLE to CLE. There was a lot more ambition for this in the room than if I'm really honest, I was expecting. I don't really mean it. There were a number of people from our care groups who wanted it to be more than maybe was in the draft. So that gives me some encouragement. People are really quite open to this. And it was almost, if we're going to do it, it really does have to have that kind of level of power that you're describing. Otherwise, it is just tokenistic. I do think my answer to the SIF question, if you like, it does lie in the framing of showing up that's referenced in the introduction to the paper. I think that there are spaces where RDaSH is seen to show up. But there are still plenty of spaces where we're not showing up. And showing up, I suppose, isn't just turning up. It sort of obviously comes with the idea of presence, but also continuity and trust. You know, a bit like the patient story that we heard, you know. So I think we've got to challenge ourselves with, okay, at that very localized level, are we visible in the spaces that we need to be visible?
I think it's something that's discussed about the board, isn't it? Is it's almost your ambition is that everybody knows, our communities know who RDaSH is and how to be part of it.
Yeah, and I guess certainly my contribution and ambition would be, I don't really mind if they don't recognise the board or the chief executive. That doesn't really matter because I think in the end the discounting factor will be, do I recognise local leaders? And I think there's a reference maybe, I think in this paper to the CAPE meetings we've started with our relationship managers and our care group leaders to try and develop a sense that they have permission to lead in this space rather than it being seen as a central thing. I think that's quite an important development over the next year or so. And it kind of comes back to Shabir's point. We don't want to be an organisation where engaging your communities is this centralised specialist function that we do, you know, almost as if it's so precious that we might get it wrong and go wrong. It needs to be a very permeable thing.
Yes, absolutely. Thank you. Good.
Yeah, so I suppose I've got 5 points, and I think some of them are amplifying on that. Yes. It talks a bit in the paper about accessibility, but I guess there's a spectrum of accessibility that we need to think about. First of it is actually literally having somebody in the room with you, but then enabling contribution, and then moving forward, being counted, having a voice, you know, we show up but we're not heard, and then being one of us, you know, the difference between coming into a room but then being told to go out when everyone's having dinner. There is something quite different in terms of some of the ways that accessibility can be seen. I think the second point is around diversity appreciation. So there's something in terms of interviewing all of our people with lived experience. So they're experts by experience rather than experts by education in the meeting space, about understanding that there's a stereotype placed on them. So I need easy read. And actually some of our staff need easy read as well. So actually our diversity isn't because we've got people with lived experience, it's because of the fact we're valuing everybody and their differences, whether they're an expert by experience or an expert by education. And I think we've got to frame it like that, otherwise we're doing things special for a group of people rather than appreciating the diversity that we've got on it. I think my third point is a really practical one, is that, you know, we here in Scunthorpe today, we go to Rotherham, we go to Doncaster. So there is something about the where, but there's also something about the when. And, you know, we get a certain set of people with lived experience because they don't work or they work shift patterns. We don't get people like us because of the fact that we don't have our board at night or in the weekend. So there might be something we need to lens through practicality around where we would access other people that we might not be listening. I'm sorry, I've got 2 more points there. I suppose one of the things that I think, and I feel like Toby's paper is a bit of a PDSA cycle come to an end and then we're moving into another one, is around thinking about the impact of lived experience and what it means for us. So this is particularly when we're thinking about trauma-informed ways of working. So like for me today, I come here after a quite significant bereavement at Christmas. And so in that, if we were speaking about something in here, I would be an expert by experience who might be quite affected and not able to speak to that at this point in time. Whereas maybe before Christmas, I would maybe feel more confident in the space of speaking to being a carer. And I don't know whether we always do that check-in to see what might be our trauma points, which might silence us. That equally applies to when we've got people lived experience in here. And I guess it really struck me with our patient story. You know, the man didn't want to even be with us. And that's a projection, but we've got to think about that in terms of how we show up or how people with lived experience might show up when we're talking about things that might be quite traumatic. You know, like we serve sometimes mortality papers like Dermot did today, very sensitively. However, there are people that have lost people by suicide. There are people who have failed. So it's just thinking about that. And then I guess the final point, and I absolutely agree with what you're saying, Toby, we don't show up and say, I am this. But that then does a flip side. So I was on a peer review recently with yourself, wasn't I? And one of the things we were asking is, do you have contact with your board? Do you have contact with people? No, I don't. Do you know who I am? Oh yeah, you come down all the time. What do? A matron now? And that's Steve. Oh yeah, I see Steve all the time. What does he do? I don't really know. No.
Oh,
That's not the answer. But I guess like when I work with communities and go in there, sometimes I'm Dr. Jude.
Yeah.
And sometimes I'm that woman with pink hair that people want to speak to. You know, like I suppose it does matter, but it doesn't matter that people recognise what we're associated with and what we are. Because for us, it might not matter that, you know, but for a CQC company, they've never met the board. Well, they have.
Yeah.
And it's how we privilege that, isn't it?
Yeah, absolutely. Yeah. When we ask you what a chair does and we go,
So you sit on it too.
Dermot.
I think a lot of points have already been made, so I won't go over them again. But I think the main one I've got that's remaining is just the evaluation of this, because I think it is so different to kind of what a lot of the trusts are doing, and I think it would be really kind of helpful to see kind of really good systemic evaluation of kind of what the outputs of this are.
So I suppose my reaction to that, I mean, you and I have had a couple of goes at trying to work out how to help grounded research to help us to do that. And I think possibly outside the room, we may want to consider whether we need a different enterprise that is coming with a different lens. I guess I probably wouldn't choose the word evaluation in the sense that implies we're trying to pass or fail. I know that's my projection. So much as almost as Jude said, how do we optimize this?
Yeah.
Which I think is an ongoing journey.
Yeah.
And although we tend to emphasise our difference, I get why we do that, and I'm comfy with that. Thanks, Reg, for what you said. There are other enterprises in public services that are trying to do this stuff. They've probably been on this journey for longer than us, and we could learn a lot from. And I think maybe part of working out who could help us is maybe to go look in a slightly more concerted way for that. So look, we're now at a point where we've sort of reached enough maturity that we think we wouldn't be wasting your time to have these conversations. So yeah, maybe that's the way to go at it. Does that make any
No, that makes
sense?
a lot of sense.
You know,
Yeah, my point just all backs up what Toby's very last point, because I suppose maybe it feels what we're doing is unusual, but that might be for the mainstream public sector. Probably.
Absolutely.
I suppose I've seen this work perhaps a lot more flexible in the voluntary sector.
Yeah.
Maybe sitting alongside or reaching. So I can see there's some difference, but I think I'm with Toby. It's important to celebrate, but not get over congratulatory, because there has been a lot of this work in different places. I do think it's the public sector is perhaps just switching on a bit late. That's on behest of those that we're trying to catch up really. And I think I think Jude's point about PDSA, the next round might be, you guys are doing this brilliantly. Let's learn from you. What can you teach us, kind of thing.
Yeah.
So
Close it down with a comment that Glenn gave, where someone he was talking to referred to us as our NHS trust. And not your NHS trust, not the NHS trust, not our NHS trust. And that's what we need to be. NHS belongs to the people. And it is, that was a really nice thing to hear. Somebody actually thought of us in that way. You any closing marks, Toby, or can we just go to receive your report?
I would just invite people to reflect on the conversation, and if there are further thoughts over the next month, it'd be really helpful to hear them in whatever format, and then we'll think about how there is some co-production and co-design of a June session. In my ideal state, but we may not get to this. It would almost not be led by us, but it does permit us to have a conversation with ourselves, which is the Shabir Dave point, as well as a conversation with others. And I probably do want to come out of that with the sort of practicalities that Jude was talking to, because I suspect for people who are not in this boardroom but are in the leadership of this organisation, they bought into the philosophy, but it's the really practical stuff that trips us up and then undermines our authenticity. That makes any sense?
No.
So, yeah.
Thank you. And the recommendations are on the cover sheet to the report. You can read them. There is obviously that issue of how we know that the community involvement framework is being delivered, but we've got some time out, and we can discuss the whole, particularly that issue of board buying, and want the better word, but our own personal feelings about this agenda and how we make it real, not being passionate, because it can get passionate. Can we agree those recommendations? Thank you. I will be pushing to get the public part of the board through by 3:15. So we've got about an hour.
We've only got 3 papers left, Chairman. We'll probably go for a walk in that time.
Famous last word.
Oh, yeah, I know.
The promises and priorities scorecard. Toby, please.
Okay. Thanks for reviewing this routine paper. What did I want to stress, and then take questions? I think I probably really wanted to stress the pecking order. The pecking order has been with the board before. I'm not about to do a quiz. There's just a couple of panicky looking faces. We're not going to do a quiz. The pecking order has 7 items in it. Why am I doing that? It just feels at a really busy time with national policy announcements, like reasserting the pecking order is quite important. So, oh my goodness me, national oversight framework, which is important, the this, the that. We owe our leaders and ourselves being really explicit that we've agreed a pecking order, unless anybody's sitting there wanting to change it. We then need to practically use that. So that feels like an important thing to stress. At the back end of the paper, there are a number of not necessarily smaller things, but actually pretty very important things that will contribute to promises development next year. Rumit's questions already animated Steve's obligations around Promise 22. exec colleagues have already mentioned the Dialogue Plus momentum and the switch off of CPA on April the 7th. So those feel like things that are going to move forward some of our measures. And then I suppose, Kath, the last thing to emphasise, I guess, that there are some sort of, I mean, this is really difficult to say because Crystal Palace have gone a long way down the league, but there are some sort of persistently near the bottom success measures that have actually been persistently near the bottom for the last year. Yeah, number of them I've got, number of them Carlene's got, you know, and they're near the bottom because they're hard, and some of them are near the bottom because there's a lot on. But I guess there's something about, you know, setting ourselves an ambition that over the next 6 months, the ones at the bottom are maybe have actually got a prospect of moving up. Am I making sense? Because otherwise it's almost like, well, that is the bottom third. You know, you are the wolves of RDaSH. You're always going to be there, and that's not where we want to be. So those are my comments. But that's me trying to emphasise the storyline. I'm very open to questions about promises or other reflections on where we're at.
That's right. I thought it was really good, kind of, as ever, honest assessment of where we are, and some fantastic progress that we've made. But to your point, Toby, about the bottom thirds, and relevant to, you know, whether it's the launch of the financial plan or performance management cycle, or we've got too much on at the moment, kind of April or stroke May, whatever you're shouting, but it feels like a collective re-engagement, you need some oxygen in this, some of this stuff, and some energy that a concerted set of leadership stroke town hall could start to change something. You know, for the 94% of people that haven't been directly impacted by what we've gone through during the change management, there's kind of a pent-up positivity that you can tap into.
Yeah, and a lot of the lower third are actually relatively centralised things. So it's interesting. When we started this journey 3 years ago, I seem to recall talking about distributed delivery versus, and probably the expectation at that point was the most complicated things would be the highly distributed things. If you apply that lens, that isn't true. A lot of the middle group are very distributed. Some of the top group are very centralised, and some of the bottom group are very centralised. So it's an interesting play.
Just occurred to me is that this was a 5-year plan that we're almost halfway through.
We are indeed.
That was suddenly very scary when it was about it. Time passing and all that. Any more questions to respond? Yeah.
I think it's just an observation really that the honesty is the important part of this, that in organisations where people do finding fudges to get these to go green so they can say how well we've done. This isn't self-congratulations. Just thought process.
Really important that we do a good job.
The pecking order is still okay, he says, checking it, but nobody's uncomfortable because we didn't quite get to the moment with region where we had to say thanks ever so much for your stuff. It's 3rd out of 7. I'm not being flippant, but you could imagine, because the starting point on the other side is this is your top priority. Our position is it's in our top 7, but it isn't our top priority. Our community stuff and our safety stuff is our top priority, and I think we all get that, but particularly for care group and directorate leaders, I think it's quite a protective thing for us to talk to and for the board to be really clear. I know it's never simple, there's always nuance, but in the moments where we have to choose, we have to choose.
If there are no further questions, well, the obviously the recommendations are on the front, but we particularly recognise that continued focus in H1 of 26-27 on Promise 14, which is what we think we recognise work that needs to be.
And I think that picks up the sustainability concern that gets mentioned. So I suppose that's in there, Chair, just because it isn't explicit in the paper, not because I think we're going to miss it, but because I think otherwise the risk we just move on. And I think the point I heard from Richard and colleagues at November's board was sustaining it's really important.
24th, wait.
Well, you can.
We didn't take a snapshot at 2:30 one Friday afternoon when everything was at fold. Really unsustainable. Thank you. We move to those reports that come in Philip's name. So we start with our strategic delivery risks. It's not the back. The artist previously known as that.
Thank you very much. Three things that I want to draw to the attention of the board today. One is content is often the key focus of this, but you'll notice that actually format is pivotal this time we've presented it. It's in a different format. We worked with 360 Assurance and responded to some of their feedback around adjusting the format. So that's why it looks different today, and it looked like that probably during the last month or two whilst committees have seen their individual risk. And I think it's important that it's not just to make it look nicer. I think there's actually, it's driven something about the content in there that it better demonstrates the links between the assurances that we receive and what we've done to try and mitigate this. But then I think it also draws out where the gaps were, or gaps are in fact. So I think within the document, again, I've not tried to just immediately plug every hole, because I think it does, the change in the format has driven out. There are things we need to do, more things we need to do to mitigate the risk and seek out assurances. And that's why I think that the final column and the section at the bottom is in need of work, and over the next 2 months before the board sees it again, that will be the focus from my perspective with the lead executives on that. The second point was that just to confirm, these have been through committee in the last 2 months, so that process is still working. People aren't having sight of these in between the board. And I think the third thing is really my reflection today, that as we've gone through the discussions of all the topics so far, I think we did touch on the word SDR once, but actually I think we've touched on the SDR throughout the meeting. And I say that because there's SDR 1 and 5, the point we just made a short time ago about community involvement framework is really important. That's the nub of that, about working with our communities to make a difference, to make change. We talked several times around data and its availability and its use. Rachel, back in the pod report, Steve about radar and PISA, the getting gritty comment that I think was in there earlier on, and Dermot, you talked about that info share with primary care. I think it shows that the importance there of data availability and its so that we can use it. We talked about links to primary care, neighbourhood working. We've got real life examples, whether or not it's from Dr. Falk or Dr. Shah around GP insights, but it shows that that is important to us. I talked about shared information, shared record, and a thread across probably a number of the strategic risks and a number of the discussions we've had today around staff or leader development, again, through the TNA, through the link to the people plan and the ABC. This is something that's throughout this organised and throughout the strategic delivery risks about the importance of supporting our staff, the leaders, and how pivotal they are. And I think when we get the feedback about the induction and the LDO, we'll know how and staff survey, how people feel that they are supported and better able to help mitigate these risks. So I think we've had a good conversation about the SDR, perhaps even without realising, but I think that's very important, because these were the 5 things we said would take us off strategy. So if we talked for 3 or 4 hours already and not mentioned them, I think we'd be worried we're talking about the wrong thing. So I think they're in there. I'll leave it there and see whether or not there are any questions.
It is a very good point. It's that the SDR is a living, breathing document we use it, even when I would say this is an SDR. At least it's the same thing as it's to me.
But can I raise the same thing? I have a feeling I raised Dave's committee or the PIP committee. I guess, I mean, I like the new format. I think the thing we've got to push ourselves on is, okay, so we want to tackle, X, Y, Z. The things we're doing are this. This is roughly what will tell us we're better. I guess I need to be able to connect how much better it needs to be to connect with the top line number. And I appreciate it isn't painting by numbers, but if we're saying in order to get to a rating of 8, we need our managers to feel fabulously comfortable with working in communities, well, A, what's fabulously comfortable, and B, how many of our managers? We've got 555 people. Is it 150 leaders? Would 120 be good enough? I'm not trying to create real difficult boundaries, but I just think a bit of precision.
Yeah.
I mean, for me as an SRO on this and colleagues as well, I think that just might top off what we've got.
Yeah. Otherwise, there's a danger a little bit about, oh yeah, we've made lots of progress in there, but actually we need something to tell us that a sizable quantity of our leaders are in.
Absolutely, because the public sector pitfall is always that people want prizes for effort rather than results, isn't it? You know, so yeah.
Right, thank you. I've got Kathy and then Jo. I think.
Thank you. I mean, people might recall, might have forgotten, but as chair of the audit committee, I do get the opportunity to go through these in colleagues who own them. And I think we talked about this structure and the presentation of assurance and the gaps, so we can focus on that. And to your point, Toby, also discuss that so that we can manage people's expectations from where we are now to getting to that 8. For example, target scores, that's March 26. So you can see, especially if things are multi-year, you can see that journey to the target or not, you know, where there might be variances, we might need to reconsider what needs to be done. So I think that's just a sort of added contextual thing. And if we can work on that and continue to work on that, I think it will pick up what you've just observed.
Yeah, thank you. Jo.
Yeah, I perhaps should have picked this up in paper actually, but I'll take the opportunity now if that's okay. Under SDR1, around the inability to work effectively with diverse population, I think we have moved on quite significantly in understanding our diverse population in terms of data and knowing where we are not serving that community. I think when we wrote these, we didn't know the nuance of that. So if we refer to the paper that is appended to the promises report that Toby's done that went to paper about health inequalities, and also the data that we've brought to board before about where we are underserving some of our communities or perhaps over restricting some of our communities, which puts us in a stronger position. And we are at the moment doing road shows with each of the clinical directorates to go through their own data so they understand what the diverse community picture is with some of their particular services rather than a trust-wide view. So whilst I don't think we're yet at the point where we are effectively working with those communities, I think we've done a lot in the last year to understand where we need to do better. So I wonder whether we need to represent that in the update in the evidence.
Yeah, but I think it touches on that, but I think it's about keeping that refreshed.
Yeah.
I think, like I said, you essentially we've moved on.
Yeah.
And what you've also just added, how there are some planned actions around those roadshows that we need to reflect in there. So that's always good. You know, it's always a moment in time when it's captured and all the people that can contribute.
Thank you. Toby,
A number of SROs were far-sighted enough to move their delivery deadline from March to July. Some were not, and we're now in January. So I guess my query is where there is still March in the box, are we say, is this paper telling us we'll get there, or is that something we need to have a bit of a sniff round? And if so, could we do it quite quickly?
I think that would be a very valuable check-in with each of the executive leads. For the point of Kathy's point of that journey is towards at least getting to the target or readjusting. So yeah, that could be.
Yeah, let's do that. We add that into the decisions then.
Yes. Yeah.
I mean, I've presented that kind of cheekily, but I mean, I just think it's a serious.
No, it is serious.
We're saying here in January, if we're not going to get there, let's say we're not going to get there. It's absolutely fine. Let's then be really clear, kind of what the gig is and reset.
Absolutely. Thank you. Can we just agree to receive and note the update position for each SDR? Thank you. To the operational risk report. Vote please.
Okay, so we'll continue to present this to the board using the acronym, therefore focusing on high tolerance, not just high risk, high scoring risks. I guess I would say this, but I believe that we continue to have an improving process around the moderation and scrutiny by our risk management groups. So we're very much focusing on the actions and talking to the risk leads about what they are doing to mitigate them. Taking conversations with them about the description and scoring things outside of it into a slightly separate forum, but really focusing on how we can make a difference in those actions. I think we've got some good track record of doing that. Risk management meets again on Tuesday. We're very much focusing on the moderation of the risks that are presented here and on the risk registers. What we're also starting to look at is also what's not on the risk registers. And by that, what I mean is the round of delivery reviews before the very recent, there was a particular comment made around it being more difficult or awkward for teams and services that don't have risks. Obviously, it's good that we have a number and we're excited on them, but Siobhan has done some work analysing the registers, taking it down through the directorates into the teams and identifying that there are areas of the organisation that don't have or have very few risks, and we're just as interested in them as we are in sort of trying to moderate what's already got. So that's again demonstration, I think, of a really positive approach to risk management across the organisation, and it includes the ones that we are most concerned with at the moment in the paper, which will be, say, focus of our NGO issues.
Yeah, thank you. Dave?
I know that I should only comment about the overarching process, which I really support. I think it's very good. Can I be bad and say on the detail, because I think it's great to see it in its full glory, because I think it's helpful to get our own heads around it. But I was just a bit surprised about the ligature comment about great oaks, presumably on doors and bedrooms, is on the risk register, that we haven't sorted that immediately. If number one is on our sit back to your priority order.
Yeah.
And safety is the number one thing.
Particularly given the refurbishment.
And it might not be appropriate to, I was detail free, I'm sorry.
Steve's obsession with doors. Yeah.
Yes, there is one thing I am known amongst staff is around doors.
Yes.
In terms of Great Oaks, so as part of the redevelopment, all the doors have been changed. So we did all the bathroom doors with the anti-ligature sliding door from Kingsley as part of the projected investment. Of course, the schedule and the Great Oaks doors are being replaced as part of the redevelopment. And as such, we, of course, with all ligatures, there are ligatures. So we identify what they are, place them on the risk register and mitigate against them.
So this is a post. It's all been done now, but they just haven't done the alarms. This was the old.
These are the Insta-stop doors. As part of the refurbishment of Great Oaks, we are having the single door that we agreed at Board of Sage installed within Great Oaks as part of the refurbishment.
With you. I'm with you. Thank you.
I can show you
Perhaps
that.
for
I thought this week.
Perhaps for the benefit of the minutes, that the Windermere door installation, colleagues are working through what it would take in July, what it would take now in July for us to do the Windermere installations. I mean, we're doing it in July. It means we've got doubtless many conversations. That will then be the end of the door story. At which point move on to windows, do we see? Is that right?
I can still consider this door story.
Yes, you should do Christmas
Energy
decorations.
efficient.
Energy efficient.
Okay.
Richard?
I mean, it's a good point you make. I suppose I was just trying to work it through in my mind. So to some extent, that risk is sort of usurped because we're rebuilding the whole place. However, the new doors aren't in.
Yes. So
it's still there.
Yeah.
But we're in this sort of weird hybrid state of rebuilding it. So do we step the risk down? Do we leave it? Or, I was just trying to work it through in my own mind.
I guess it's my ignorance. I thought it was one of those. We've done the refit. It's now done.
Yeah.
We just didn't do it at the same.
Yeah.
So
No, it's a great question because I was actually trying to work through the methodology.
We're on doors.
Yeah, but just quickly, it's not a new risk. So this has been a continued risk throughout the monitoring period of time. So it may read as though we've only just put it on.
Yes.
David, it's been over for a significant time.
Yeah. Thank you.
Can I just get back to this notion of making it a lot more uncomfortable to have no risks than to have risks?
Yeah.
Which is a construct I wholeheartedly support. Can I just check, when we're doing that thinking, is there an overlap between people who are not reporting any risks and people who are not reporting many incidents and people who are not? I mean, is that a map that between yourself and Steve that we can build? I'm not trying to be accusatory, but if we're going to have the conversation at once,
Yes.
either you've learned how to do incidents and you're not doing risks, that would be interesting, or you're not doing either.
Yeah.
We need to have that conversation. And while we're there, and again, for purposes of the minutes, we did have 1,000 people who hadn't looked at radar. I'd love to be able to know the exact number today, but obviously the Richard Banks is about to rerun the numbers, as I recall, and issue them. I was going to say by the 1st of February, but that feels a little bit tight. We'll give you till the 6th, because we've got to get to this point of the 31st of March where everybody's been on radar. Well, I think we've got to be at that point. Yeah, there might be if the person who drives, if the lady who drives the forklift truck wants to tell me she doesn't need to go on radar, that's absolutely fine. But yeah, it feels like a thing. The countdown.
We'll pick that up.
We're not going to publish their names in Trust Matters. That was just like that was just one of my really awkward ideas. Let's not do that.
Okay, but no, we'll write a minute to that effect too. Could we then agree to receive and note the operational risk report? Thank you. The mortality report of 28 is in my name and is simply for information, been through the policy committee. One of the papers that are just here for information. Can we receive that? Unless Richard has something he wants to tell me.
No, beyond commending Dermot for the nature of the reports we received and for the tweaks that we're making.
Thank you. I am not aware that we have any other urgent business, because we've had none so notified. May I ask whether there's anything from today's debates that anyone thinks should be added to the risk register? Anything that's sitting in your brain thinking this ought to go on the risk register? Everybody's looking very quiet. I didn't think about it.
What's the describing weights in your fleets on? Is that on?
So that's what we'd asked Philip to check in November's board meeting.
Did it go on?
I think it.
I'm not just checking because it was mentioned in the board.
So that is now on the risk register. Right.
But I suppose if it's on the risk register but isn't featuring,
then
I would question whether the risk calibration has been done.
Yeah.
Quite right. So could we ask our Andrew to just have another look at it? I know I presented where it's going to get fixed, but I mean it's going to get fixed by about June.
Yeah.
After a year and a half of not being fixed. So I mean it still feels, to Richard Chillery's point, like a live risk that's got a solution down track.
Yeah, absolutely. No further ones, and that closes that item. We have no public questions because we have no public. Yes.
Well, are we ever so sure they're not? Because I don't ever recall ever having no members of the public. We're absolutely sure they're not sitting in a room somewhere. Because Cora Turner must have other things to do. I can't imagine what normally with us.
But no,
It's usually some government.
Ian not seen anybody on the screen.
Oh, you'll get the email afterwards, Phil.
Yeah, could not get it.
Okay.
Through sheer skill and anything else you want to call it, I'm now 4 hours in front.
Must be constantly saying we might run behind you.
So I now resolve that because publicity would be prejudicial to the public interest by reason of the confidential nature of the business to be transacted, public and press are excluded from the remainder of the meeting, which will conclude in private. I have agreed that TVC stay in the room for obvious reasons. Can we do that? In which case, thank you so much, 316. If anybody needs a loo break, now is the time.
Cheers.